All right, so one good thing about the GI tract is the GI tract we all have experience with, and nutrition we all have experience with, good and bad experiences. So in a way, though, I'm a fancy plumber, right? The GI tract's fancy plumbing. And what's nice about the GI tract is everything you put in from filet mignon to a Twinkie, sooner or later comes out as poop. And I get paid for talking about poop. That's literally what I do. I get paid for talking about poop, and I make a living at it. So we're going to talk about the GI tract. Okay, so here's our outline. We're going to talk about some symptoms and some functional disorders that really, it's hard to put them anyplace else. We're going to talk about a top to bottom pathology, the kind of the way things go in, and then we'll talk about the way they come out. The kind of a logical thing. And then we're going to talk about hepatology. You know, there must be 50 ways to love your liver. All right, guys, come on. Are you awake out there? All right, this is the jokes. The medicine we charge for, but the jokes are free and worth every penny. All right. All right, so let's talk about vomiting. Now, vomiting is not a diagnosis. You guys know that, right? Vomiting is a symptom. But if you would write board questions, you think about vomiting in association with what? All right, so here we go. So bilious vomiting. Well, you think about an obstruction, right? Blood, you think about an upper GI bleed. Fever, think infection. Emesis only, you think about gastroesophageal reflux. Undigested food, you think about achalasia. Projectile vomiting, you think about pyloric stenosis, a web, an annular pancreas. A tense fontanelle, increased intracranial pressure. Adolescent female, who is nobody's friend in an ER. You think about pregnancy, drugs, migraines, and bulimia. Chronic vomiting workup. You know, so you have a kid who's vomiting, they chronic vomit. Where do you start? Well, you start usually first with an ultrasound. Why? Because it's cheap and it's safe. All right? Then maybe an upper GI contrast study, an endoscopy. Well, now, endoscopy is never first because it's expensive and there's some risk to it. But the literature tells you it's probably the best at sorting out the etiologies. But you don't start there because of the safety and the expense with it. Cyclic vomiting, or if you're from other parts of the country, cyclic vomiting. Cyclic versus cyclic, same thing. These are paroxysms. These are attacks of vomiting. These kids have these vomiting episodes where they will literally vomit up their toenails, and then in between they'll be completely, totally normal. All right? So there's a strong association with family history of migraines because guess what? This appears to be some sort of a migraine variant. The exam is normal. The history is usually pretty classic. Now, the hard thing is how much workup do you do, all right? So you get this classic history. Do you do a ton of workup? If the history is pretty classic and there's a strong family history of migraines, if you're comfortable, a lot of times you just go ahead and treat them. Now, once they start vomiting using ondansetron, a lot of kids will need IV fluids until it runs its course. But you treat it like a migraine headache. What's interesting is you use prophylactic medicines. The three that are best cited in the literature, according to the North American Society for Pediatric Gastroenterology and Hepatology and Nutrition, or NASPGHAN, which is the Peds GI Society, their Blue Ribbon Task Force said the three best ones as far as the literature are propranolol, cyproheptadine, and amitriptyline. And prophylaxis, if it suppresses and eliminates the episodes, almost diagnostic, since there's really not like a diagnostic test for this disorder. Abdominal pain. Again, associations to think about. Trauma with abdominal pain, perforation, hemorrhage, musculoskeletal injury, pancreatitis. Bilious vomiting, you think about an intussusception, volvulus increased, some sort of a hernia, adhesions, peritonitis, you think about appendicitis, cholecystitis or PID. An adolescent female, again, my saying is an adolescent female with pain in the ER is nobody's friend. PID, pregnancy, ectopic pregnancy, ovulatory pain. You see the current jelly stools. You see that on an exam, think intussusception always. And melena, you think about an upper GI bleed because it's been digested. Bright red blood, you think lower. Melena or black, you think more upper. Just as a hint. How do you assess abdominal pain? Well, the first thing is use your hands. A serial exam is one of the best ways to do it. Labs, again, a CBC is very helpful. Kind of gives you a hint about infection. A urinalysis, because abdominal pain is not GI. A pregnancy test, again, that adolescent female group. If it's postprandial, you think liver, you think pancreas. Sometimes chest x-ray. I've seen many a kid with abdominal pain, it's actually a lower lobe pneumonia. Ultrasound or CT if they don't get better. If it sounds like an appendicitis, And the exam looks like an appendicitis. The answer is always surgery, not more studies. In kids, it ruptures sooner, and I will repeat this when I get to appendicitis. They rupture sooner. If the exam and everything points to an appendicitis, the answer is not more tests. It is surgery. All right? In fact, there is some literature that you should take out a few normal appendices in order to get the appendices before they rupture, because when they rupture, it's bad, and it ruptures faster in kids. All right, so chronic recurrent abdominal pain or functional abdominal pain, or as we like to say in the business, CRAP. Yeah, that's right. In fact, this is peak season. August, September is peak season for this disorder. You guys, if you think about that for a second, if you have children, you'll understand. August, September is when they go back to school. Lots of missed schools. It's usually over 3 months in duration. Onset's like 6 to 14 years of age. They have this apparent pain. Stressors make it worse. Normal growth, normal exam. Labs are all normal. And the treatment is reassurance and education. I had one mom come and she says, I think it has to do with sleep. And I said, oh, do tell. She says, when he can sleep in on Saturday, he never has pain. Functional abdominal pain. So there are kids who have these functional disorders, and there's a lot of theories. There's some different neurotransmitters involved, and there's this criteria called the Rome criteria that helps guide that. It's actually been published, and there's 3 of them that we primarily see: functional abdominal pain syndrome, functional dyspepsia, or old-fashioned name is non-ulcer dyspepsia. You'd swear they had an ulcer, but you scope them and look, and there's no ulcer. And irritable bowel syndrome. A lot of people believe there's a motility disorder, is what they believe these are from, and the criteria helps drive it. By the way, Rome is not an acronym. The first meeting that developed these criteria was held in Rome, Italy. It's actually named for Rome, Italy. I was not there. I was not invited. Love to have seen the Colosseum. Flags, all right? Organic pain. When is something that should make you think maybe this is not functional. All right, the pain wakes him up from sleep. All right, I don't know about you guys, but it's to wake me up is not easy. The pain is in a specific spot. They're losing weight, unless that's voluntary or on purpose. Fevers, rashes, joint pain, ulcers on a mucous membrane. Look at the mouth. Guaiac-positive stool. Now, the ideal way to get that, of course, is by a rectal exam. Okay? Anemia, an elevated SED rate, family history of inflammatory bowel disease. And a family history of inflammatory bowel disease increases your risk of any inflammatory bowel disease. So if you have ulcerative colitis in the family, it increases your risk of Crohn's. If you have Crohn's, it increases your risk of ulcerative colitis. So, all right. So, a previously healthy, this is an audience response. Wake up, get your keypads. All right? Previously healthy 5-month-old presents with acute onset diarrhea. On exam, he looks well hydrated. You've seen children with a similar presentation all week long. So what's our most appropriate therapy? Lactose-free formula, oral rehydration therapy, continue the current breast formula feedings, or change to a hypoallergenic formula. All right, here we go. Got 10 seconds. Very good. All right. All right. So, infectious diarrhea. Now, infectious diarrhea can last up to 14 days. It depends on the agent that gives you that infection. All right. Now, when do you think about something else and you need to think about more workup? Well, if the kid's under 2 months of age, they're having bloody stools, they look toxic, don't disconnect your brain. Look at the kid. Do they look sick? Immunocompromised patients. They've been in the hospital recently. They've been on antibiotics recently. And if you do a stool, white blood cells, and they have a ton of white blood cells. Basically, oral rehydration if they're dry. Otherwise, the recommendation is to feed through, even if they're vomiting. Feed through, feed through, feed through. The enterocyte is a unique cell. It takes its nutrition by pass-through. If you're not feeding it, you ain't nourishing it. All right? So, you feed through. Now, it's not appropriate if you have shock or stools over 10 mils a kilogram an hour where you can't keep up, or you have an ileus. But again, those are very rare conditions. You avoid the hypertonic fluids. You avoid juices and sports drinks and soft drinks. That gives you an ongoing diarrhea that goes on and on and on, and you can't get it to stop. And actually, the reason they're having that is because you're giving them a hypertonic fluid. Feed through, feed through, feed through, feed through, feed through. In the vignette for the question, it said the kid appeared well hydrated. That was not a red herring. That was to tell you the kid looks well hydrated. If it goes beyond 2 weeks, you might then think about a trial of a lactose-free formula. We all learn about, you can get a temporary lactase deficiency in kids who get a viral illness and all that. But that's, yes, it happens, but it's pretty rare. Medications that people use for kids with diarrhea. Absorbents. Hey, you had bulk, the stools firm up, you go back to daycare, life is good. Yeah, but they're still infectious. So, are you doing any favors for your friends? But you're back to work sooner. All right, judgment call, ethics, not my bailiwick. And anti-motility agents, those induce an ileus, basically, and that's not something you want here. Probiotics, literally they decrease the severity. There's great literature on probiotics and in rotavirus, that it shortens the course. So those are actually a good approach. And then there's some others, somatostatin, bismuth-subsalicylate, and there's some issues with those that are beyond us talking about, basically not recommended. Constipation. Now, constipation is tough because there's not really a good definition of constipation. Is it frequency? How often you go? Is it consistency? Is it hard? Is it soft? Discomfort when you go? Even if it's soft, it hurts when you go? Is that a problem? The way I look at constipation is like a Supreme Court justice's quote about pornography. He said, "It's hard to define, but I know what it is when I see it." All right? So, constipation, all right? So, but stooling, normal patterns have a wide range. If we took a survey by everybody in here, your stooling pattern is probably different than the person next to you. We just don't talk about it in polite conversation. All right? Now, in infants, I was taught when I was young, skinny, and had brown hair, and I was built, the rule of sevens. The normal range of stooling in an infant is 7 times a day to once every 7 days. In children, normal children, then go 3 to 4 days between stools. Again, as long as it doesn't hurt, they're not uncomfortable, they don't have any issues with it, it may not be a daily thing, although we get very hung up on the daily thing. In children, functional behavioral etiologies are the most common etiologies of constipation. Now, this is an important topic to talk about, or discordant stooling. Some people call it infantile dyschezia. Infants are not super smart, okay? And they don't realize when they need to poop, they have to relax the anus to let it out. And so some infants, for the first few months of life, will strain and strain and strain, and they may even have soft stools, but they're straining and straining and straining, and they're uncomfortable and everything. And the problem is when the stool comes out, it's soft, and they'll cry and strain. And it's a difficulty in coordinating their abdominal pressure and relaxing the anus, okay? Eventually they'll get it. You avoid enemas, though, and suppositories, because if you do that, guess what? That's a negative conditioning, and it kind of perpetuates the process. Basically, the important thing is here, say, hey, okay, this is a normal process in early infancy, and it'll get better with time, and explain that to the family. All right, now here's a picture of what it looks like for somebody at the Med Study course for an entire week who doesn't poop. Because they're so busy studying for their boards, they're anally retentive, literally. Psychogenic constipation. So the colon's main job, not only, but main job is to absorb water. But there is no shutoff sensor. There's no feedback that says stop absorbing water. So as long as the poop is in there, the body continues to take water out of it. Now think about that for a second. If you are a kid who has an anal fissure for some reason because you've had a hard stool, you are hyperactive and too busy to stop and poop. You go to school for the first time and it's a different bathroom and you have to ask permission so you don't go at school. Or you've been sexually abused. That's one of the ones that's on the list. So you hold on to your poop. Well, the longer you hold on to it, the more water gets taken out of it. The more water gets taken out of it, the harder it is. Then when you do go, it's painful. Now, let's see a show of hands of how many people enjoy pain. No hands. Yeah, me neither. So I hear there are people who like pain. I've never met any, but I hear there are. But, so they don't like pain, so they have a painful stool. What happens the next time you need to poop? Ooh, man, that hurt last time. I think I'm going to hold on to this and put this off. But the longer you hold on to it, the more water gets taken out of it. Then when you do go again, hey, it's painful and it hurts. And this is a positive feedback loop. It's a vicious cycle. And so they get in this withholding, and it becomes positive feedback loop, and they can't break it. And then they develop these huge impactions. They get colonic dilation and overflow soiling. And then they come in to see you for diarrhea when they're actually impacted and constipated. If you put them on a softener right away, boom, you make the stuff coming around more liquid, and the soiling will get worse, and they will think you are not competent, and they will probably switch to somebody else. To get started, you've got to get them cleaned out. That's the first thing. You got to get the stool out, get the roadblock out, and then we usually end up using long-term softeners. Basically, they have to unlearn that it hurts to poop. And regular toilet sitting, then they get comfortable sitting on the stool. They learn it doesn't hurt, and eventually you can wean off the stools, but there is a very high relapse rate. For instance, when a younger sibling is born, somehow they tend to relapse. Fancy that. None of you were jealous siblings, were you? All right. All right, so let's talk about esophageal. We're going to start our top-down survey. We're starting at the esophagus and the trachea. So, embryology, I don't know how much you guys remember, but actually, the first organ that forms is the tube gut. Sperm, egg, start dividing, form a blastocyst, flattens out into the embryonic disc. You have endoderm, ectoderm, mesoderm. The endoderm invaginates in and forms a tube. And the very first organ is the gut. Most important. The tube gut. All right, so as I remind my pulmonary colleagues, the lungs are a bud off of the foregut. Okay? So they bud off the foregut, and they start off as a common tube, and then they separate and pull apart. But that old adage about anything that can go wrong, eventually something will go wrong, right? What happens is there's a problem with the separation and pulling apart. If it pulls apart, it may pull some of the esophagus with it, or it may not disattach. And so you can understand, when you understand embryology, how these develop. And you get these tracheoesophageal fistulas with esophageal atresia. That's the most common one. Or you can have the H-type where it pulls apart, but there's still a little connection. All right? So the most common is the TEF with esophageal atresia, 1 in 4,000 births. 90% of all the tracheoesophageal anomalies are the TEF. 1/3 of those, though, are associated with Vactral. And you need to know Vactral and those associations. Vertebral, anal, cardiac, TEF, renal, and limb. And what happens is you try to place an NG at birth in these kids, and you see it on the chest x-ray, like so. Hey, where's the NG? Where's the NG? Oh, wait a minute. Look at the top of the left picture. It's the very, very top. Fortunately for us, on the right picture there, they did the lateral a little bit lower, and you can see it. You know, boop, it goes down, and then it curls back up. This kid has an esophageal atresia. Isolated esophageal atresia without a fistula, you have this flat gasless abdomen because no air gets into the belly. You can't pass an NG, and then the oral secretions all collect and bubble up and bubble over. The H-type, again, they'll choke during feedings. You can end up with pneumonias. Very hard to see in a barium swallow, though, because the barium tends to go down the esophagus. Some of these folks get to adulthood and have had kind of here and there some pneumonias and stuff, and then they figure out, oh, they have an H-type fistula, and they're one of these embryologic separation issues. Esophageal stenosis and webs. Some of these kids do pretty good with the webs. Again, it's pulling apart, but the formation isn't quite perfect, and there's a web in there. Do great with liquids, but when you start solids, the solid gets stuck on the web. So, again, a lot of those can be treated without surgery. You can dilate it somehow, stretch it out. Achalasia. It's a neural problem, basically, and you basically get an lower esophageal sphincter, or LES, that can't relax. So, the food goes in, hits the LES, it doesn't relax. So then the food backs up, and it sits there, and over time what happens is your esophagus dilates. And when it dilates, it gets all stretched out and floppy. You don't have good peristalsis. And so you have trouble swallowing. You have regurgitation because stuff gets stuck at the LES, and then you end up with spillover and pneumonias. Usually in infants and children, it's part of a syndrome, and there's several syndromes that are associated with achalasia. Otherwise, it's pretty rare in children. We treat it with pneumatic balloon dilation. Put a balloon across the LES, blow it up, and stretch out the lower esophageal sphincter. Again, you see achalasia, you should think about syndromes in kids. Audience response number 2. A 4-month-old is brought to clinic because he spits up. His growth parameters are excellent with weight at the 50th percentile. The material is described as just rolling out of his mouth. He's not distressed by this, and he'll smile at you throughout the spitting up. Physical exam is normal. So what are we going to do? We're going to start acid suppression. We're going to start him on a formula designed for reflux. We're going to get an upper GI series, or we're going to reassure the parents. All right, here you go, guys. Yeah, 100%. I don't know if we've ever had 100% on any of the audience response questions, but that's the right answer, all right? So, reflux, infantile reflux, is physiologic. Now, for some reason, almost everybody believes that it's physiologic and it's a muscle problem. Actually, the latest studies tell us it's not a muscle problem, it's a nervous system control problem. Infantile reflux is because of transient inappropriate relaxations of the LES, or TISLAs, as some people call them, okay? And what that is the tone, the vagus nerve is supposed to tell it has a tonic tone to keep the LES shut. Well, the nervous system's immature. You guys know that infants don't walk and they don't talk. You never let them go on a date unsupervised, right? So the nervous system forgets to tell the LES to stay shut. It just spontaneously relaxes and opens up, and up it comes. All right? So the good news is when the nervous system matures, they'll get better, and they will outgrow it. The peak age for reflux is 4 months of age. And why is that? Probably because the volume is going faster. The volume they need for growth is going faster than their neurologic maturity. So about 4 months is the peak, and then it starts to get better, and with time they eventually will outgrow the reflux. It becomes gastroesophageal reflux disease when it's causing symptoms, all right? Causing health effects. It's causing them to fail to thrive. It's causing them pain of some sort. Asthma problems, aspirations, pneumonias. Then it becomes a disease. How do you diagnose gastroesophageal reflux disease? It is not, capital N, capital O, capital T, not by an upper GI. All right? But why do we do an upper GI? Well, because if you do pediatric gastroenterology, you see annular pancreas, you see duodenal web, you see all sorts of things that cause kids to have issues. You do it to check for anatomy. A plumbing check. I tell our residents that we do upper GIs as plumbing checks. You can't diagnose reflux. If I did an upper GI on some of you, they would see an episode of reflux with the upper GI, and then, do you have reflux? Well, some of you might, some of you don't, but it's not the way you make the diagnosis of reflux, all right? The gold standard, or as we like to say in GID, semi-gold standard, is a pH probe, okay? We put a measuring device in the esophagus and measure how much acid comes up. And we try to correlate that and esophagitis, but it's not 100%. Endoscopy, we can look at the lining, see if there's esophagitis. Is there enough coming up that we're having changes in the lining? We can do scintigraphy studies, which measure emptying, and it also can show you aspiration. Usually we make the diagnosis by history, but that's pretty inaccurate. You know, again, as I said, infants are very poor communicators, okay? So that's how we make the diagnosis of reflux disease. Reflux, It is a reassurance if they're gaining and growing and happy, and you explain to them how it's physiologic. Don't tell them it's a laundry problem. I tell you guys it's a laundry problem, but if you tell the family it's a laundry problem, they will think you're being flippant with them. There is some literature on formula thickening. Okay, thickened, it stays down better, although the dietitians hate that because it increases the caloric load, and then they tend to get very, very thick. The kids do. Sumo looking. Gastroesophageal reflux disease, especially the ones that are having poor weight gain. Again, the North American Society of Perinatal Gastroenterology, Hepatology, and Nutrition, and I'm just going to call it NASP again from now on, just because it's so hard to spit all that out. Guidelines, kids who have severe reflux and have health effects, they've looked at the literature, and there's a good number of these kids that actually have formula protein allergy. And they recommend a 2-week trial of a low-allergy formula, okay? That is in their recommendations. And a 2-week trial, not a 2-day or 2-bottle, 2-week trial, all right? We don't practice formula roulette, all right? Thickening and concentration if it's poor weight gain, and that's thought to be associated with their poor weight gain, you can thicken. Acid suppression, you can use a promotility agent if you think motility is an issue. And we do see some kids who have some motility issues. And sometimes you do NG feedings temporarily to make sure they get the volume they need and they get enough. And you can give it over a slower period of time so the reflux is less of an issue. Advanced therapies for gastroesophageal reflux disease. If you have actual esophagitis, you treat that with an acid blocker. It'll help prevent strictures and the development of Barrett's. And these are kids who are like little gastroesophageal reflux disease, a lot of times associated with neurologic problems. If they have respiratory problems, if they're having asthma and flares that seem to be due to reflux, use the medications first. If the medications aren't helping and you do have respiratory difficulties, then you think about surgery. Again, kids with chronic neurologic difficulties. Again, probably vagus tone and feedback to the lower esophageal sphincter is affected. Those kids a lot of times will not get better, and you have to think about surgery in those kids. The most common surgery is the Nissen fundoplication. Take the fundus and wrap it around to create a nipple valve effect at the top of the stomach. There are a few others out there, Thal fundoplication, a few others, but you guys are not taking the pediatric surgery exam, so you probably don't have to worry about those. You shouldn't. All right, eosinophilic esophagitis. All right, so these are the kids who have symptoms just like reflux. They have epigastric pain, they have vomiting, but they don't get better with an acid blocker. I remember when we didn't know about this entity, but we had these kids that we would treat them like we treat all the other reflux kids, and they didn't get better. And then you do an endoscopy, and you do a biopsy, and as you look at this picture, it looks pretty darn red or pink, and that's eosin, and these are loaded with eosinophils. Well, eosinophils are the type of white cell that do allergy, and this is an allergic etiology as far as we can tell. So there's two approaches. One is an elimination diet. Elemental formulas, elimination diets, there's several of them out there, or topical steroids of some sort. And there are advocates for medical therapy, and there are advocates for the elimination diets, and that hasn't been sorted out yet. There's still a lot of controversy what the better therapy is. Some people say, hey, it's an allergic process. You need to treat it with dietary changes. There are others that say, we can't figure out what the elimination is very well, and we have to go all the way to elemental formulas. Maybe we should treat it medically, and then we can feed them normally without all the expense and hassle of trying to do all these eliminations or special formulas. So, again, the jury's still out on that. Esophageal infections, predisposing factors. HIV, cancer, high-dose steroids. For instance, some of your asthma kids who've gotten like a burst of steroids or something, or we see the most with kids who have diabetes. And the most common one is Candida. We also see CMV. We also see herpes. And they will show up with dysphagia, odynophagia, and chest pain. And if they have one of these predisposing factors, you got to think about an esophageal infection. Caustic ingestions. These always happen on Friday and Saturday nights. The acidic ones taste bad. So the kids will tend to take something acidic in their mouth and spit it out. And they'll have mouth burns, but they tend to be okay. Their esophagus tends to be okay. Alkaline ones, unfortunately, are pretty tasteless. And so they will tend to go ahead and swallow those. but unfortunately, it'll produce a coagulative necrosis in the lower esophagus. And so they swallow it, and then we have to do an upper endoscopy and look and try to assess how much damage they have. There is a 12 to 24-hour window when it's crucial to look at these kids. Now, you're saying 12 to 24 hours, wouldn't you look right away? It's interesting in that if you look too soon, you don't see the damage. You can't see it. It isn't obvious. If you're doing that 12 to 24-hour window, the studies tell us that that's when you can see the damage, have a good idea, and assess it. After 24 hours, if they have damage, your risk of perforation goes up. And I will tell you as a gastroenterologist, we avoid perforation. Just saying. All right? Do not induce emesis. Why? If it was bad going down, it's still going to be bad coming back up. Do not try neutralization, because to neutralize, basically you have to put something of an opposite pH that is bad to neutralize it. Don't try to place an NG, because if you place an NG and it is damaged, you may cause a perforation. Treatment on this, antibiotics, steroids. Again, nobody has tons of these kids. There are some people who advocate for antibiotics and steroids. It's probably not harmful, but it's not proven. There's no literature to prove that therapy, and so it's a very individual what people actually practice. Pill esophagitis, we love these. There are some pills that when you swallow them are more likely they start to break down a little bit in the swallowing tube. They get stuck, and you'll have a pill esophagitis. This also is typically, in my experience, the adolescent male who tries to dry swallow his pills. Okay? Tetracycline, doxycycline, aspirin, NSAID, slow-release potassium. Those are the big players usually we see this. Esophageal foreign bodies. Some people at our church jokingly call me a fisherman because I go fishing for things all the time. Number one are coins. Kids love coins. If they're stable, you can watch them for 12 to 24 hours, and a large number will pass on their own. Once it gets in the stomach, pretty much it'll pass all the way through. On chest x-ray, the coin is face forward. Now, if you remember embryology, all right, and when they separate, right, it pulls apart. So the trachea has that soft spot in the back where it's come off the esophagus. Also, that allows the bolus of food, which bulges a little bit in the front of the esophagus, to go down the trachea where there's a soft spot. If a coin goes into the esophagus, it tends to be flat when it's at rest. So the coin will fall into the esophagus and it will be flat, en face. If the coin goes in the trachea, it will tend to fall in that soft spot and will be on edge. So the chest x-ray, face forward if it's in the esophagus, edge towards you if it's in the trachea. Sometimes in older kids we'll see meat. Adolescent boys don't really use their teeth, they just inhale. So we will see a big chunk of something. In Memphis, it's often venison. We've got a lot of deer hunters that have a big chunk of venison in their distal esophagus. Do not use meat tenderizer. You know, meat tenderizers to break down the meat and to make it more tender. What do you think the esophageal tissue is really? Yeah, okay, enough said. Endoscopy is the method of choice for removing a foreign body. If you do some sort of a Foley method where you run a Foley by, blow up the balloon, and pull it back, well, if there's a coin and you pull it back and it flips into the airway, you're in worse off shape than you were before. It's more control when you have an endoscopy. You can look at it, you can get a hold of it, and you know where it's at. Disc batteries, ingested disc batteries in the esophagus especially, are an emergency. What happens is the esophagus collapses, you get a local current which causes necrosis, and in several hours, they'll perforate the esophagus. Kids, older kids that have a foreign body that get stuck, you need to think about eosinophilic esophagitis. Why in the world is this 12-year-old got something stuck in their esophagus? Usually because it's thickened and inflamed and they have eosinophilic esophagitis. And here is a kid who had some dysphagia, and for some reason they did an MRI, and there is a coin in the esophagus. Magnets. These rare earth magnets now are being used in toys, and they're cool. and they're fun, and they're really sticky. Trouble is, if you ingest a rare earth magnet, gets into your GI tract, this peristalsis can pull them apart. Then what happens is they can get into the small bowel, and then two loops can get beside each other, and they can stick together. Then what happens is you get fistulas, you get perforations because of the area where there's ischemia because of these magnets are stuck together. These are very, very dangerous. You try to get them if they've had a rare earth magnet ingestion. Try to get them while it's in the stomach and get it before it gets into the small bowel. They're trying to ban these because of the danger for children of these rare earth magnets. Esophageal perforations, a very, very, very rare occurrence. Usually there's a connective tissue disorder. Ehlers-Danlos, Marfan's, epidermis bullosa. Endoscopy is a little risky in these kids, and we try to avoid it. And then there's Borheim's syndrome, which is a spontaneous rupture. In older kids, it tends to be with coughing. Severe coughing is the most common cause of this. You have vomiting, straining, barotrauma, blunt chest trauma. If you see it in a neonate, which happens occasionally, it makes you wonder about some sort of a muscular defect. There's some sort of muscular defect in that area where there was a perforation. All right, so our audience response. Our 8-week-old infant presents with projectile, non-bilious vomiting. His electrolytes just demonstrate a hypochloremic alkalosis. On ultrasound, there's a thickened pylorus. The appropriate next step is correction of the electrolyte and fluid status, surgical pyloromyotomy, upper GI series, or a barium enema. All right, guys. Okay. All right, so most of you got that it's A. Few of you went to B. And this is an important point about pyloric stenosis. All right? All right, first off, it's very common. 1 in 750 to 1 in 200 live births. Boys are 6 times more likely than girls. But don't ignore the girls. I've actually had a personal experience where I had a child with severe spitting up, and the general pediatrician said to me, well, it's a girl. I said, but girls can have pyloric stenosis, and the child did have pyloric stenosis. 6 times more likely than boys doesn't mean girls don't get it, all right? It's usually about 1 to 2 months of age. It's a progressive projectile, non-bilious, because it's at the pylorus, emesis. Not present at birth, though. You're not born with it. It thickens with time. The electrolyte changes, if prolonged, result in hypochloremic alkalosis, and that is a big flag. How do you make the diagnosis? In theory, you feel the olive. I will tell you, when I know the ultrasound is positive, I can always feel the olive. Okay? Ultrasound is a good way, and then an upper GI. The treatment is first to rehydrate and correct the electrolytes, and then a surgical pyloromyotomy. This is not like a ischemic event. This is not an appendix that's going to rupture. This is not an intussusception or a volvulus. This is a thickened pylorus. This kid's electrolytes are off. There's a higher risk of anesthetic with this kid with their electrolytes being abnormal. This kid is dehydrated. It's affecting their vascular flow. You're going to fix this kid's electrolytes and his fluid status before you send him to the OR. It's a very important point. And I will tell you, if you notice the question, as somebody who's written a few board questions, this question, we led you to the diagnosis, then ask you the management. All right? In a way, it's kind of sneaky. I admit that. Because you have 2 chances to miss. In a way, if you miss the diagnosis, you're in a world of hurt. Hopefully we don't do that when we lead you down to the diagnosis. And then you can mess up if you pick the wrong management. But a lot of times, we give you the information to make the diagnosis and then ask you a management question. Because in a way, that's even more important. More important than being able to say this child has pyloric stenosis is to realize this kid has a hypochloremic alkalosis and this kid is dehydrated. And that this kid needs his hydration status fixed, no matter what the cause. In theory, this kid now, we told you the ultrasound showed the thickened pylorus, so he has pyloric stenosis. We told you that. But in theory, if you're in clinical practice and you have a kid who has vomiting and has hypochloremic alkalosis, you think, and you don't have time to get, you're waiting for the ultrasound tech to come in. This kid could have some sort of a, other etiology. They could have a duodenal web or something, but you've got to fix the electrolytes. And that's the key here. You've got to fix his hydration. That's the management thing that's the most important here. All right, this is an upper GI showing you the string sign. One of those old pathognomonic things. You can see that string where it's going through that thickened pylorus. All right, so we've made it through the esophagus, and now we're in the stomach. All right, outlet obstruction is pretty rare. There's pyloric webs or atresias, and if you have those, unfortunately, the treatment is surgical. Then there's something called microgastria, and it's basically where the stomach doesn't develop its full size, and they have this small tubular stomach. It's usually associated with other anomalies. They tend to get better as the kids get older. So basically, use continuous drip feeds, get them growing. Once you get them growing, things will get better with time. Rebuilding a stomach is not something that's surgically possible, so you need to help them grow that. Erosive gastropathy, very common issue. Stress will do it. Stress like shock, sepsis, burns, head injuries, prolapse. If you have severe vomiting, that stomach prolapses up to the base of your esophagus, and you can get Mallory-Weiss tears. Probably the most common cause of kids who come into the ER and tell you they've vomited up a few clots and a little bit of blood is a Mallory-Weiss tear. There are drugs as well that will do it. Aspirin, non-steroidal anti-inflammatory drugs. This time of year, we see it, at least in Memphis. We have all our kids, all our boys who are going back and they're in football camp. And, they didn't do what they were supposed to do all summer. And so they didn't work out all summer. And then they are going and working out and their sores get out. And they're taking a handful of ibuprofen, just about a handfuls. And they come in, and we've had some actually come in and they're vomiting up blood. And they have an erosive gastropathy from the high doses of ibuprofen they're taking. And then exercise, long distance runners. Of course, my wife says the only reason to run is for a good shoe sale. All right, so non-erosive gastropathy. Number one, Helicobacter pylori. Most common cause far and away in children. We also see Crohn's disease. There's also an allergic gastritis. And if you see eosinophils, you do an endoscopy, do a biopsy, you'll see eosinophils in the wall. Meniere's disease. This was described by a French physician. So you have to, the pronunciation is French. I was told it's Meniere's. I am not French by any means, but that's the way I was told it's pronounced. This is a severe protein-losing enteropathy, and it's basically a child who gets their first CMV infection, and it seems to affect the stomach lining, and you look at it, and it's this characteristic thickened, swollen folds, and fortunately, since it's an infection, it will resolve over several months. So it's temporary, but it's a pretty interesting and unique type of gastropathy. Peptic ulcer disease, again, one of my pet peeves. You cannot diagnose pediatric ulcer disease on an upper GI series. Okay? Children are smaller, the stomach is smaller, it's folded, you have all sorts of folds in a smaller area, and what happens is the barium on an upper GI or the contrast, whatever they use, can pocket. And you'll see these pockets of contrast, and it'll be there's possible ulcer there. And I can't tell you, I wish I got paid for every scope I did, that they have called an ulcer on an upper GI somewhere, and there's no ulcer. All right? So when you see that, remember, pediatrics, you cannot diagnose an ulcer on an upper GI in children. Endoscopy and biopsy is the definitive test. It lets you look for other causes as well. Almost always in children, almost always, it's H. pylori. If not, it's usually secondary to something else. And the two associations that sometimes show up on board exams is Cushing's ulcer for increased intracranial pressure and Curling's ulcers associated with burns, children that have burns. H. pylori. Now, Again, you guys are getting my pet peeves. Antibody tests for H. pylori are not recommended. I have personally never, ever, ever ordered one. And this year, I figured out I've been doing Pete's GI for 29 years. I know you're shocked because it's hard to believe I've done it that long. Not even a snicker. All right. Antibody tests mean exposure. All right? And exposure, a lot of people are exposed to H. pylori and they clear it. If all of you, if you've had the measles, mumps, and MMR, measles, mumps, and rubella vaccine, and I went and did an antibody test on all of you for mumps, you'd all have an antibody for mumps. Do any of you have mumps? No, because you've been exposed to the vaccine and you have an antibody. So the antibody testing is worthless. Worthless. It's not recommended. And we see kids, they go to their pediatrician, they have abdominal pain, they do serology for H. pylori. So if you have proven disease, which we can do with endoscopy and biopsy, there's triple therapy, PPI, clarithromycin, and metronidazole or amoxicillin. Then you have to follow up after therapy. You can do a repeat endoscopy, or there are some reliable tests. There's the breath test for H. pylori, and there's a stool antigen. The stool antigen is very specific. It's an antigen made by the H. pylori. So if you have the antigen in the stool, it means the H. pylori is still there. It's very specific. It's not very sensitive because it doesn't always pick up unless you have enough protein there and enough production by the bacteria. So but it's a good way to follow up because it's very specific if you've had an infection and you've treated them. Peptic ulcer diseases, ulcers from other causes. Zollinger-Ellison, it's pretty rare. Gastrin-secreting tumors. If you see a child and they have an ulcer and it's not H. pylori and you can't figure out a cause, you check their gastrin levels and they're high, then you look for gastrinomas. Strong association with multiple endocrine neoplasias type 1. You've got to look for that. You've got to evaluate them for that. The other one is mastocytosis. And these are mast cells that accumulate throughout the body, including the GI tract, and they result in acid secretion. And have seen several of these mastocytosis kids. Malrotation. All right. So, malrotation is very important. Rotation is very important. So, when we are forming, our bowel, because it's so important, grows faster than the rest of us. Okay? And so it grows faster and it herniates out and then comes back into the gut. All right, you guys remember this? Right? All right. Well, so as it comes back, it rotates 270 degrees counterclockwise. Why is that important? All right, so our abdomen is a rectangle, right? A rectangle. It's not a square. Some of us are more square, but it should be a rectangle, long. What happens is it rotates. Now, if your bowel doesn't rotate, it's on a very short pedicle. Short pedicle means it's longer. It's not as tied down, and it's freer, and it can turn easier. If it rotates 270 degrees, what happens is, and then it's on the diagonal. All right, so it's on the diagonal. That's a long pedicle, so it's shorter. It's actually you could almost use the Pythagorean theorem that a squared plus b squared equals c squared. And who said you didn't use math today? All right? So that's why rotation is important, all right? So if it doesn't rotate that 270 degrees counterclockwise, the bowel isn't fixed. It's got a long pedicle, and it's loose, and so it can rotate on its mesentery. But if it rotates on its mesentery, all the blood vessels and everything go through that mesentery, and then you end up with a midgut volvulus, and you end up with dead bowel. And that is a bad thing. Most present in the first month of life. 90% of these kids will present in the first year of life. They'll have this acute bilious emesis and distension. You do an upper GI, you'll see this bird's beak after the duodenum, and it is a surgical emergency. This is an emergency. This bowel is ischemic. What's fascinating is, if it's found incidentally, they recommend correction. Correct it. Fix it. Do the surgery. You do an upper GI, see the small intestine not across the midline. Because if it's going to turn, if it's going to volvulus, It isn't going to be during the weekday hours. It's not going to be when you're free and you got things to, time to do something. It'll be when you're on your trip to Europe or something. That's when it's going to happen to you. So here is an upper GI of a child who has malrotation. This is not a volvulus. If you look, the barium's going through. It's not twisted or anything, but you notice that the bowel did not rotate. It goes across, the stomach comes across, and then it's all in the right side of the abdomen. This is a malrotation. It didn't rotate at all. It's all right there. This is a volvulus. Barium goes in, and then it literally looks like a bird beak. And it is right there, and this child needs to go right away and get this surgically intervened. All right, so a healthy 10-month-old presents with abdominal pain, vomiting, and bloody stools. A palpable tube-like mass in the abdomen is present on exam. The appropriate diagnostic study is an air contrast enema, a barium enema, an abdominal CT scan, or surgical exploration. All right, here we go, guys. All right. So the correct answer is the air contrast enema. All right. So this is a vignette that points you towards an intussusception. That's that tube-like mass. Occurs between 2 months to 5 years of age, and the peak is in the 4 to 10-month range. Again, in infancy. They'll present with pain, vomiting, bloody stools, and they'll have these current jelly stools. When the bowel telescopes inside of itself, it affects the blood flow to the mucosa, and so that current jelly is kind of sloughed off mucosa cells. That's what that is. All right? It's the reason it's this gelatinous kind of stuff. Usually there's a lead point, a Peyer's patch, a polyp, some sort of a leading point. And you feel this, again, sausage-shaped mass. You diagnose it and treat it. It's therapeutic to use an air contrast enema. Literally, you use the air as your contrast because that way, if it does perforate or whatever, you don't have barium in the belly. That's why it's an air contrast enema if you think it's an intussusception. If you can't get it to reduce, you send it to surgery. What's fascinating is the recurrence rate, because most of these kids will have like a Peyer's patch, they've had a viral infection or something, and their lymphocytes are active and they have increased follicle size. 10% recurrence rate. Guess what? You do an air contrast enema again, and you reduce it again. So literally, you keep doing air contrast enemas unless you can't reduce it again, then it's surgical. All right, real quick, another audience response one. 13-month-old presents with several bloody stools. Absolutely no GI symptoms. He is in no distress. Plain films of the abdomen show no evidence of obstruction or ileus. But on rectal exam, he's got maroon guaiac-positive stool. He's got what? A formula allergy? He's got an anal fissure. He's got a juvenile polyp, or he's got a Meckel's diverticulum. What do you think, guys? All right. He has a Meckel's diverticulum. All right. The maroon should be a hint. Remember what I told you about dark and light? All right. So bright red, if it's anal fissure, it's usually bright red. Juvenile polyps, most of the time, are bright because they're lower. Formula allergy, again, that's coming from higher up, although it can be bright. The Meckel's is maroon, though, because it's coming from something above the colon, has to go through the whole colon to get there. So the Meckel's diverticulum is an embryologic leftover. It's actually the lead point from when you do herniate. It contains all 3 intestinal layers, which means it has pluripotential. And so because of that, you end up with some ectopic formation of some types of GI tract lining cells that you don't see other places. So 80% of the kids can have ectopic gastric lining, and 20% will have ectopic pancreatic tissue. Now, the pancreatic tissue doesn't cause you any problems, but the gastric certainly can because they are acid producing. It's the #1 cause of lower tract bleeding in children because what happens is that ectopic gastric mucosa will produce acid and ulcerate. The diagnosis is most of the time by Meckel scan. It's a tracer that collects in gastric tissue. So you do a Meckel scan and you'll see 2 dots. You'll see a big stomach light up. You'll see this little dot down the right lower quadrant. Yeah, unfortunately, you have to surgically resect this. Meckel's follows the rule of 2s. We like it. Rules of 2s. 2% of the population have a Meckel's diverticulum. Now, again, it may not have ectopic mucosa. It may not cause you any issues. But literally, 2% of the population in studies have a Meckel's. It's within 2 feet of the ileocecal valve. It's usually 2 inches long. It's 2 centimeters in diameter. 2-to-1 male to female ratio. I don't know why having a Y chromosome makes it more common in males, but it does. My wife would probably make a comment. And if it's going to bleed, it usually does so before age 2. So, and here's an actual picture one of our surgeons gave me of an actual Meckel's diverticulum. Like I said, it looks like normal mucosa pretty much, except the inside, when you open it up, there's gastric mucosa that's ulcerated. Intestinal atresias, 1 in 5,000 births. So again, not that rare. Of course, the most common is duodenal atresia. Over 50% of atresias are duodenal. And it's associated with other anomalies. Cardiac, GU, anal rectal, esophageal, and there's a huge association with trisomy 21. Jejunal and ileal atresias are not usually associated with other anomalies. They just seem to be some sort of a random event. And then colonic atresias are extremely, extremely rare. Here is a great picture of a duodenal atresia. This is the famous double bubble sign, all right? Duplications, again, interesting embryologically. When the bowel is herniating, I'm giving you a lot of embryology. I hope most of you, this is a review that you remember embryology. Hopefully most of you can remember medical school. When the bowel herniates, the bowel lining actually goes very rapidly as well. And the bowel actually becomes a solid cord, probably so it's stiff enough to herniate. And then after it comes back, it recanalizes. Well, when the bowel recanalizes, sometimes it will recanalize in 2 channels. And you will end up with 2 lumens. And so you'll end up with these cysts or all sorts of different funny, anomalous things. Well, of course, that bowel is fairly normal bowel. It has pleuropotential, and some of them end up with ectopic gastric or pancreatic mucosa. So they can ulcerate, they can bleed. Most of the time, though, they don't tend to be like the Meckel's, and most of them don't have gastric mucosa in them, but the mucosa is secretory. And so they form these cysts, and they will secrete fluid, and with time, they'll show up basically as a mass effect. They'll have obstruction. They can be a lead point for an intussusception. So they're found at surgery when you do surgery for symptoms. There's a lot of time when they're found. You've had this kid, and basically they have the severe symptoms, and you do surgery. Of course, the other thing is a lot of times they'll show up on ultrasound as well because they are like fluid containing and they're cystic. Here is a ultrasound and a intestinal duplication cyst. So on the left, on the ultrasound, you see the normal intestine, and then there's this cyst, and again, it's got fluid in it. Carbohydrate malabsorption. When we don't digest the sugars, the bacteria that live with us like to. They love sugar. So bacterial fermentation produces gas, hydrogen specifically. Also produces a acidic pH, so you tend to get diarrhea, and you tend to have plus or minus pain with this. Now, lactase deficiency is very rare until after 2 years of age. Because, well, we'll talk about it in a little bit, but human milk has lactose in it. So how do you make that diagnosis? We can do a lactose breath hydrogen or a mucosal biopsy and actually measure lactase levels. A temporary deficiency is very common. That's the most common cause of a disaccharidase deficiency. Fructose sorbitol, these are sugars primarily found in juices and soft drinks. And if you take a very high load it's above your enzyme levels, and then you end up with diarrhea as a result. So all these kids who take all these fruit juices, all these infants that drink all these fruit juices, or toddlers who love our fruit juices, they come and see us for diarrhea, and they're taking a gallon of fruit juice a day. And was it milk allergy? And everybody suspects and blames it on milk allergy, and then it's the fact that they're drinking a gallon of juice a day. And usually I'm like, let's start by stopping the juice and putting it back on milk. So sucrase isomaltase deficiency, 5 in 1,000. All right, so this is actually the most common inherited disaccharidase deficiency. And this is an autosomal recessive process. What's interesting is that you do fine early on because most of the time you're getting lactose. All right, and then when you start introducing solids and other foods in the diet and you start getting a little other sugars into the diet, you start having diarrhea and the fermentation, the gas, and all that. And so sucrase isomaltase doesn't show up at birth. It shows up when you start putting those sugars in. Again, secondary carbohydrate malabsorption, temporary lactose intolerance is the most common form of this. Congenital transport defects, again, these are kind of the things you look at the table and look at. A-beta lipoproteinemia is a defect in ApoB. And if you're having trouble with fat absorption, you end up with steatorrhea. And fats, 9 calories per gram, guys. Proteins and carbohydrates are 4 calories per gram. Great energy source. You end up not growing and gaining weight well. Chylomicron retention disease. You have trouble with chylomicron exocytosis. Again, fat problem. You end up with steatorrhea and not gaining weight well. Congenital sodium and congenital chloride diarrhea is a problem with the exchangers. Chloride for bicarbonate exchanger or the sodium for hydrogen exchanger. And so you'll have the corresponding change in pH in the stool and alkalosis or acidosis because you're not getting the exchange and your pH is screwed up because you're not exchanging appropriately. Other ones, Hartnup disease is a transport defect for free amino acids, neutral amino acids, and you end up with a pellagra-like syndrome. Blue diaper syndrome is from tryptophan transport defect, and what happens is it's a transport defect. It gets in the diaper. When the diaper is exposed to air, it oxidizes and turns blue. So it's the blue diaper syndrome. Lowe syndrome, which is not a desire to go to a hardware store every day, is a lysine and arginine transport defect, and you end up with developmental delay. You kind of need those, cataracts and rickets. And acrodermatitis enteropathica is a transport defect for zinc, and you end up with this particular dermatitis around the mouth and the anus, diarrhea, and again, poor weight gain and growth. Short gut syndrome. We can't leave the bowel, the intestine, without talking about short gut bowel problems. Causes of, there are many roads to short bowel syndrome or short gut. The most common one is necrotizing enterocolitis in the NICU. Volvulus we've talked about. We have kids who have atresias, multiple or long segment atresias. Gastroschisis, long segment Hirschsprungs. There's a lot of causes. The problem with short bowel is since there's many roads and many mechanisms, what you lose differs from condition to condition. And the bowel has different tasks in different areas. The duodenum is where you absorb iron and folate and calcium. And so you'll have anemia and osteopenia if you have duodenal issues. If you lose your ileum, well, that's where you reabsorb bile salts and B12, and you end up with anemia and fat malabsorption. If you have short bowel, you can do much better if you have your ileocecal valve because it keeps things in the small bowel longer for more absorption. You do get absorption with time. The mucosa gets hypertrophied and it'll improve. And we have an intestinal rehab clinics all over that work with these kids to try to enhance their use of their gut and basically try to get them off parental nutrition. If they're way too short, you think about intestinal transplantation if the kids are going to be stuck on parental nutrition for a long, long time or never be able to get off. That's a double-edged sword, though. Celiac disease. This is one of these hot things right now. Celiac disease. Gluten is evil. Gluten is wicked. Gluten is vile. We all need to take gluten out of our diet, or everybody in Hollywood is taking gluten out of their diet. Which, of course, was a man on the street interview they had, and they asked somebody, "What is gluten?" I don't know what it is, but it's bad. They have no idea what it is. Now, so gluten is a protein that is in one family of grains, all right? And that family include the ones normally in our diet are wheat, rye, and barley. And they interact or cross-react with the human transglutaminase in our mucosal cells. There's a 33 amino acid long epitope that's very resistant to digestion, glycine and prolamine rich. And what happens is that fragment in some folks will basically cross-react, and they'll have this immune reaction to this protein. But then this protein that they make an antibody against, again, is cross-reacts, and so they end up making an antibody that attacks tissue transglutaminase. And so you end up wiping out your own villi. And so some people have described celiac disease as an autoimmune allergy. Have a unique thought process here. In Northern Europeans, the occurrence rate's 1 in 250, so it's very common. Fascinatingly, it's associated with a human leukocyte antigen, or HLA types, DQ2 or DQ8. DQ8 and DQ2 indicates susceptibility to celiac disease. You're susceptible if you have it. Gosh, well then all we'd have to do is let's just look for DQ2 and DQ8 and we know who is susceptible. Trouble is, 35% of the population has DQ2 or DQ8. So 35% of the population, in theory, is susceptible to celiac. Doesn't mean they have celiac, means they're at risk, they're susceptible to it. Presentation. Well, if you're under 2 years of age, it tends to be the classic presentation. They have diarrhea, they have poor weight gain. Because they're malabsorbing, they tend to get distended, because if you don't digest it, the bacteria will, and they'll make gas, and you get this big bloated belly. And they get muscle wasting because they're not being nourished. In older kids, the symptoms can be different. Again, it can be the classic diarrhea, poor weight gain, distension, muscle wasting. But sometimes the kids, the signs are a lot more subtle. Yeah, they'll have poor weight gain. And they probably are malabsorbing some micronutrients. And so some of these kids, it's like, well, they're skinny, but they're not bony skinny. But they'll be kind of like 14 and haven't started puberty yet. Everybody else has started puberty, but they haven't. All right? Another thing that we see, there's a rash called dermatitis hepatiformis, which is associated with celiac disease. Again, a cross-reaction. And if you see that rash, that's an indicator of celiac disease. So it has multiple presentations. Again, associations for celiac disease. It is associated with other autoimmune diseases. Remember I told you, many people view this as an autoimmune allergy. Well, if you have one autoimmune disease, it increases your risk for the other ones. These are the diseases that are associated with celiac disease. Insulin-dependent diabetes, autoimmune thyroid disease, Sjogren's syndrome, collagen vascular diseases, and IgA glomerulonephritis. Interestingly, trisomy 21, 12% of kids with trisomy 21 have celiac disease. And then IgA deficiency is an association with celiac disease. And here's our diagnosis, all right? So the screening, the antibody testing, all right? IgA antimycelial, IgA anti-tissue transglutaminase, IgG anti-gliadin. There's an IgG anti-tissue transglutaminase as well. The best one is the IgA anti-tissue transglutaminase. The gold standard, though, is still villus atrophy on biopsy and then clinical remission on a diet. On the left, on the top is normal. Look at those villi. Those finger-like villi, they're in the lumen of the bowel. The nutrients are floating by. They're grabbing them. We've got great, lots and lots of surface area. We are designed to absorb everything we put in. Isn't that awesome? Except the controls by not putting it in if you want to control it. But if you have celiac disease and you have an antibody reaction, you attack your enterocytes, the bottom picture on the left is what it looks like. You literally have attacked your enterocytes and you have mowed off all your villi. You do not have the big, long absorptive surface area. Those beautiful villi that were hanging out there absorbing for you are gone. And things come through, they pass through, and you can't use them. You can't get them. Microvillus inclusion disease. This is the number one cause of congenital diarrhea. All right? Number one cause of congenital. It's an autosomal recessive, and you do a biopsy in these kids, and what happens is the EM shows that the microvilli are trapped as these inclusions in the apical surface of the enterocytes. So they literally are not getting these microvilli for absorbing out on the surface of the cells. Unfortunately, the treatment for this has to be parental nutrition or small intestinal transplant because nobody's figured out a way to fix the exocytosis of these cells. All right, a few other sorted things. Tropical sprue. Nobody knows what the pathogen is on tropical sprue yet, but you have to spend at least 3 months in the tropics, and you have this severe malabsorption, and the treatment is oral broad antibiotics and nutritional supplements. I would be willing, if somebody would let me, to try living 3 months in the tropics and take the risk. All right, Whipple disease is a very severe malabsorption. Frankly, you'll see an arthritis, a polycerositis, and CNS symptoms with it. It is diagnosed by biopsy, and there is a bacteria associated with this one, Trophermia whipplei. And basically, this is a hard bug to kill. It takes 6 months of antibiotics. That is a lot of antibiotics. That's a long time. All right, appendicitis. I told you we'd get to this again. This is the numero uno childhood surgical emergency. The kids present with fever, nausea, vomiting. Initially, it starts off periumbilical. You know, the visceral nervous system isn't great. It's very vague. It's not like our skin where we have a great position sense. And so it's kind of vague. It's around the belly button. And then what happens is it continued inflammation, and it builds and it grows. And then it will migrate to the right lower quadrant. Well, the scary thing is a sudden pain release. All of a sudden, wow, I feel better. The pain is gone. Unfortunately, in children, that usually means it's ruptured and the pressure is gone. Rupture is much, much faster in children, and the younger they are, the more rapid it is. The diagnosis, physical exam, ultrasound, barium enema that it won't fill, CT scan. Those are your diagnostic tools. But again, it's a surgical emergency. Typhlitis, this is patients who have reduced immunity. Transplant patients, immunodeficiency diseases, that kind of thing. That's fecal inflammation. The x-ray shows us bowel wall thickening and pneumatosis intestinalis. Basically, it's like neck and somebody's immune system doesn't work well. And treatment is bowel rest, IV fluids, antibiotics. These folks can be fairly sick and need to be pretty aggressive with the treatment. Ulcerative colitis. So we have made it down. We're in the colon. All right, so ulcerative colitis in the name, colitis. It's only the colon lining only. What symptoms do they show up? They'll show up with fevers, pain, and bloody diarrhea. Now, they can also have rashes. There's a couple of rashes that are associated with it. Clubbing, arthritis, and 3% will have primary sclerosing cholangitis, which sometimes shows up before the ulcerative colitis. Endoscopy with characteristic findings on biopsy is the diagnostic method. About 60% of them will be P-ANCA positive. In Crohn's, it's 15%. There's these antibodies that are out now that are supportive, but they are not diagnostic. There are panels that are being marketed. They're supportive, but again, they are not definitive for inflammatory bowel disease. Ulcerative colitis, the other thing to mention is there's a colon cancer risk with this over the long term. It's a 1% risk a year after 10 years. Again, this is old data. Our treatment is better these days, but nobody has repeated any of these studies about cancer risk. Crohn's disease. This is a disease that I have to admit I hate and I dread. Usually it's wonderful kids, wonderful families, and they have a chronic disease that we do not have therapy that cures it. We have therapies, we talk about remission, but we don't have cures. These kids will have this the rest of their life. Crohn's disease can be anywhere from your mouth to your anus. I have seen kids who were diagnosed because they had perirectal disease. I have seen 2 children who had unrelenting mouth ulcers and turned out to have Crohn's. The old name is regional ileitis. It likes the ileum best, but not exclusively. There is a correlation with family history. There's also genes now that are being associated with Crohn's disease. The best is NOD2. These are genes that have effects on mucosal immunity and also interactions with the flora. How do they present? Well, again, it can be anywhere mouth to anus. How does it present? It varies. It's a great mimicker. Crohn's will mimic a lot of other things. A lot of times you'll see weight loss and growth failure. That's one of the more common ones. Inflammation burns calories. If you have Crohn's and the inflammation is taking your calories, it affects your growth. Anal fistulas, fissures, abscesses. Again, diagnostically, the way you make the diagnosis is endoscopy, and you do a biopsy and you see full thickness inflammation and you see non-caseating granulomas. Granulomas, in theory, are pathognomonic. The trouble is, only 40% of the patients will have granulomas. Sometimes it's where the disease is. If it's in the small bowel, you know it's got to be Crohn's because it can't be ulcerative colitis. But sometimes it's hard, and they're confusing, and it's hard to tell the difference between the two. Antibodies to Saccharomyces cerevisiae and 60%. Again, 60%. These antibody studies are supportive, but they're not diagnostic. Drugs. What drugs do we do for inflammatory bowel diseases? Well, steroids. Steroids have been around as long as I've been taking care of kids with inflammatory bowel disease. And they work great. Man, they're powerful immunosuppression agents. They induce remission, have horrendous long-term side effects, but short-term use, man, the kids feel great. They eat well. They gain weight. And parents look at you and like, why can't we just stay on the steroids? They feel great. And then you talk to them about cataracts and high blood pressure and diabetes. But it's a big hammer to get them into remission real fast. 5-aminosalicylates. 5-aminosalicylates. These are topical. They work through the 5-hydrotetrafolate pathways, and they're topical anti-inflammatories. They work good for mild to moderate disease. There's various formulations, and you select by how they're released. This is pretty much works for mild disease, but the higher level, they aren't all that useful. 6-mercaptopurine or azathioprine. These are immunosuppressive agents. They work for moderate to severe disease. They get you off the steroids, but they turn down your immune system. There's lots of concerns about long-term use and some of the things that can happen with long-term use of immunosuppression agents. Methotrexate, another immunosuppressive agent for moderate to severe disease, gets you off the steroids, especially for Crohn's, especially if there's a problem with 6-MP or azathioprine. It's funny, the big studies were published many years ago, used 6-mercaptopurine or azathioprine. A rheumatologist I know told me that if they'd done methotrexate, we'd be using methotrexate. It's just what has been studied and published. And then the new drugs, the biologics, the infliximab, adalimumab, certolizumab. Yeah, say that fast 3 times. These are antibodies to tumor necrosis factor alpha. Now, tumor necrosis factor alpha, we knew was a part of the inflammatory cascade. Now, when I was young, this was first described in cancer patients, and it's thought what made the cancer patients very skinny and scrawny, and they called it cachexin. And it turns out it does more than that, but it's a very, very important pathway for inflammation and inflammatory bowel diseases. And it works very well for moderate to severe diseases and fistulas, especially in Crohn's. Now, it's a protein. These are antibodies, so you always have a risk of an allergic reaction. Interestingly, it's comforting to know that our body has all sorts of redundancies and mechanisms, and it seems to work its way around all sorts of stuff. In some folks, it seems that the response fades with time. It's like the body finds a way around when you're taking out one of the normal pathways. The other thing that we learned with these drugs when we started using them is tumor necrosis factor alpha was extremely important for control of tuberculosis. Who knew? Well, we found out. We started using these drugs, and folks who had tuberculosis, it got reactivated. So one of the caveats with using these drugs, you have to test for TB before you can use them. Cyclosporin, a powerful immunosuppressant agent. We used to use it for transplants. Lots of side effects, and you have to monitor levels. And we don't use it much anymore, to be honest. Antibiotics. Antibiotics work great in the short term. Like kids who have fistulas or whatever, it'll help them heal. But the trouble is, if you use them, the response fades out. It's probably because it alters your flora, is how they work as a mechanism. But anyway, short term they work, but long term the response will fade. Nutritional therapy. In Crohn's, this works. Clear literature that it works. If we put the kids on an elemental formula and just feed them and let their gut rest, but some sort of a formula, the Crohn's will get better. Trouble is, people don't tend to volunteer for being on just a formula. They find it very redundant, and it's not where they want to be. Other nutrition thing with inflammatory bowel diseases, vitamin D and calcium. Even when the kids are in remission, it seems like they have trouble with bone accretion. And so one of the big things now is to make sure you follow their vitamin D and calcium. Those of you who are in general peds, you need to make sure your pediatric GI docs or help them and make sure the vitamin D and calcium levels in anybody with inflammatory bowel disease is kept up to snuff. Surgery in IBD. In Crohn's, it's reserved for strictures and complications. Because if you take the bowel out, what will happen is the Crohn's will come back in the residual bowel. Crohn's disease used to be one of the leading causes of short bowel syndrome until we got smart and realized you take some bowel out and it'll just come back in the bowel that's left. So Crohn's itself by itself is not an indication for surgery. In ulcerative colitis, in theory, a colectomy is curative. Of course, if you see any kind of dysplasia, you need a colectomy. Emergently, you do it in toxic megacolon. Some kids present with ulcerative colitis, and they never go in remission, and basically the bowel doesn't work right, and basically from the get-go, they go straight to surgery. The surgeons now have created several procedures for kids who have ulcerative colitis and do get their colon removed. They create this surgical pouch from the distal small bowel. They take up and create a pouch with basically a bend in the bowel, and that slows down the transit time, and they create this new pouch that's a reservoir to collect stool. They do stool more than the average person, but not as much as somebody who just has an ostomy. All right, audience response number 6. A healthy 4-year-old presents with a history of large amount of blood with stools. He has no abdominal pain and normal growth. On physical evaluation, the anus has no fissures, but the stool is guaiac positive. Most likely diagnosis here, rectal prolapse, Meckel's diverticulum, Crohn's disease, or a juvenile polyp. Another 100%. Awesome. This is a juvenile polyp. This is actually what they look like. This is a stalk, and then they have this kind of a strawberry, mucousy surface to them. And then on the outside of it, the yellow stuff is poop. 1% of all preschoolers will have a juvenile polyp. And on pathology, these are inflammatory hemangiomas. They're thought to be some sort of response, and it's a hamartoma. They're benign, and they will cause painless rectal bleeding. And when they stool, the stool comes by, it irritates, you get some bleeding. These are benign. You remove them, they don't recur. You don't have to follow up. Well, with more scopes or anything, if they have 1 or 2 or a low number of these. If there are more than 5 juvenile polyps, then that is diagnostic of something called juvenile polyposis coli. These are kids that make juvenile polyps. And there is a long-term risk of malignancy of these because they keep making new polyps. You have to follow them with regular colonoscopy and removal of the polyps. So let's talk a little bit about polyp syndromes. Now, as a gastroenterologist, these are fun because we get to go scope and loop and snare and remove polyps, which is kind of fun, to be honest. All right. So first off is PHTS, P10 hamartoma tumor syndromes. And there's a family of these, and the defect is the same, but the manifestations are different. One of the fun ones is rubalcaba Meyer-Smith. And what the board question writers love is they have macrocephaly. They have pigmented penile lesions. And you get to put penile in the question, that word. Okay? And hamartomatous polyps. So, if you see pigmented penile lesions, think Ruvalcaba Meyer-Smith. Cowden, Banyan-Zona, and Banyan-Riley Ruvalcaba are three different types and different presentations of polyp syndromes. And these are folks who have multiple hamartomatous polyps of the skin, mucous membranes, breast, and thyroid. Another polyp syndrome is Proteus. And these are, again, hamartomatous polyps. Proteus is characterized by hemihypertrophy. And they'll have giantism of their extremities, angiomas, and pigmented nevi. And the key in this one tends to be the hemihypertrophy is one of the most diagnostic things. Polyps with hemihypertrophy. Pooch-Jaeger syndrome is a completely different than the P10 gene defects. This is a defect in the STK11 gene. And these kids have hamartomatous polyps as well, but the diagnostic thing with these kids, or the harbinger, is these mucocutaneous hyperpigmented region lesions. So they have freckling of the mouth and inside the mouth. And you look inside the mouth and there's freckling around the lips. These kids have all this freckling. Now, I will say one time I have followed a child who has this. She also had red hair and a lot of freckles to start with. So it was real subtle that she had a lot of freckles and she had more around her mouth, a whole bunch around her mouth. It turned out she had Pooch-Jaeger's. But that's the characteristic thing, is you see this excessive freckling. The Pooch-Jaeger disorder is also associated with other cancers. Breast, cervix, ovary, testicular, and pancreas. And you have to screen and look for those, because if they have that STK11 gene defect, they're at risk for these other cancers. And then the last one to talk about as far as polyp syndromes is familial adenomatous polyposis. This is a defect on chromosome 5q. It's 1 in 10,000. Most of them are autosomal dominant, but with variable penetrance. Basically, they have adenomatous polyps. Now, the most common is Gardner's in this family of disorders with this gene defects. And they will have soft tissue tumors as well as all the polyps. They have desmoids, they have sebaceous tumors, epidermoid, lipomas, fibromas, and osteomas. Basically, these kids have a lot of polyps. They get regular screening, endoscopies. You follow them with time, and lots of scopes, lots of polyps. And then we still don't have any good therapies except for surveillance in these kids, unfortunately. A few other polyps to talk about. Neurofibromas. You guys know these. The characteristic thing, of course, is the cafe au lait spots. 25% of folks who have one of these neurofibroma disorders will have GI tumors. Lymphomas are the most common malignant tumors of the small intestine. Usually it's a Burkitt's lymphoma. And then the other lymphoma is the H. pylori-associated gastric malts, or mucosal-associated lymphomas. Adenocarcinomas in kids are extremely rare. The risk factors, of course, are polyposis syndromes and inflammatory bowel diseases. Carcinoid tumor is also extremely rare. They are benign tumors of the appendix, where that's the spot where they're the most common. Again, extremely rare tumors in kids. A few things, again, that really don't fit anywhere. These are wall defects in the GI tract. The omphalocele. All right, so this is basically when we talked about herniation of the bowel, it doesn't make it back. It gets stuck. And it's basically the umbilicus. They're usually greater than 4 centimeters, and they will contain solid and hollow organs covered by the membranes. 3/4 of them will have other anomalies. Of course, by default, all of them are malrotated because the rotation occurs as the bowel comes back in. 25% of them will have a major chromosomal anomaly as well. Gastroschisis. Now, this is different because it's to the right of the umbilicus, and it's anywhere from 2 to 5 centimeters, and the intestines are hanging outside of the gut. They're soaking in the amniotic fluid, and they end up being short, thickened. They tend to be desmodal. They're all malrotated. Basically, this bowel is outside of the lumen of the abdomen, and it requires immediate surgery. Nobody knows what causes this, why they develop a defect, why is it there. There's all sorts of theories, but nobody knows for sure. All right, so now we're at the tail end of the GI tract and anal rectal disorders. So embryologically, a lot of the things in the GI tract are very logical if you understand embryology. A lot of things get screwed up at the very beginning. In the beginning, there is a common cloaca, which is basically Latin for sewers. The cloaca was the common sewers that ran down the middle of the Roman streets. So there's the tube gut. It is literally all together in the beginning. And then there's a membrane that grows in and separates the urogenital system and the rectum from each other. But as I said before, anything that can go wrong will go wrong. So when the membranes don't form properly, you end up with all sorts of fistulas and connections that shouldn't be there. And this sounds like an obvious statement to anybody who thinks about it, but boys are different than girls. All right. So let's talk about the males, because they are easy. Perianal fistula. Basically, the membrane formed and the bowel didn't quite connect with the anus, and so it's in front of the anus. Well, a lot of times that could be primary repaired. They just pull it back and bring the bowel through the anus. You don't even need a colostomy. Unfortunately, there are some kids that membrane doesn't completely close, and you have a rectourethral fistula. Literally, you're peeing out stool. This is unfortunately the most common anomaly, and this requires a colostomy. You got to get the stool out of the urinary tract. So they disconnect it, create a colostomy, and then they'll go back and repair it later. And then a rectovesicular fistula, again, right into the bladder. Again, not good. It requires a colostomy and a later repair. But again, in a way, the males are much easier because they don't have all the other anatomy down there. Female, well, as you would guess, this is can be a mess. Perianal fistula, perineal fistula, again, it's in front of the anus, close to the vulva. It depends on where it's at, but most of the time that can be primarily repaired. Again, they can bring it back, they can bring it through the anus, and you don't have a colostomy. The vestibular fistula, where the rectum basically empties into the opening of the vagina. Again, so there's poop coming out of the vagina instead of out of the rectum. Requires a colostomy and later repair. And then there is something called a persistent cloaca. Again, it's all one big common channel. All the urine, all the stool, the reproductive organ, it all ends in one big opening, which is a mess. Basically, from the GI tract standpoint, they usually do a colostomy. Disconnect it, get it out of the way, and then the urologists have to come in and immediately do something from a urologic standpoint to protect the urinary tract, which is sterile normally. Imperforate anus, again, the bowel didn't recanalize all the way through to the anus. This is the most common one, is a very low one. And the sphincter's intact, it's there, it just doesn't, basically it's not open. The higher it is, the more problems there are. And there's a higher incidence of this, again, in trisomy 21, that they have imperforate anuses. Rectal atresia is extremely rare. If you have an atresia there, again, there's usually some colostomy that's done, and they'll try to repair it later, although a surgeon cannot create things like God can. And so basically there's usually a lot of problems there with controlling stooling and, again, a lot of problems there with the anal rectal system. Rectal prolapse. So we go from more rare and esoteric to something that you guys will see regularly in your office. Rectal prolapse is extremely common in kids under 2 years of age. Muscle tone's not as good. They don't think much. And the etiologies, top 3 etiologies of rectal prolapse. Number 1 is constipation and straining. Again, easy to deal with if you see that and you soften their stools. Number 2 is diarrhea, probably because of they're having diarrhea and they have excessive contractions, and that will cause rectal prolapse. Number 3, cystic fibrosis. The stools have this thick, sticky mucus, again, because they have the chloride channel defect, and that is an association that requires evaluation. If you see a kid who has a rectal prolapse and you don't get a history that makes you think constipation or diarrhea, you need to look for cystic fibrosis. Rarely, and I mean rarely, does these kids ever need any kind of surgical intervention for rectal prolapse. Normally, you deal with whatever the etaology is, and with time, they will quit prolapsing, and as they get older and the muscle tone gets better, it will go away on its own. Common anal problems, for people who study for board exams. Anal fissures, tears of the anal lining from large stools, common cause of bleeding. Sometimes they'll heal and you'll see a little tag. A tag around the anus a lot of times is a signal that you've had constipation, a fissure that has healed. It'll heal, come together, and you get this little tag. Hemorrhoids, again, constant straining because your residency is so hard on you, they don't let you go to the bathroom regularly, and so you end up with hard stools and you end up with hemorrhoids because you're straining. And pruritus ani, that's a dermatitis or infection. Sometimes it's detergent. Some people, there's different etiologies of this, but the itchy butt. All right. You have the answer response. Hirschsprung's disease is diagnosed by delayed newborn stool passage, abnormal barium enema, thickened nerve fibers, or an absence of ganglion cells. Yeah, pretty close. Absence of ganglion cells. All right. Hirschsprung's, again, fairly common disorder. It's 1 in 5,000. All right, so the nerve cells in the GI tract migrate cephalocaudal, head to toe. Basically, Hirschsprung's is when the nerve cells don't get to the bottom. Because there's no nerve cells there, the bowel doesn't get the signal to relax and open. So the aganglionic bowel stays contracted. The bowel above that has nerve cells sees this backup of stool, and it will dilate because it actually has ganglion cells. So you do a rectal suction biopsy, and you don't see ganglion cells. That's the diagnostic thing. You need to think about it in an infant who doesn't stool in the first 48 hours of life. At 2 to 4 weeks of age, a kid who has Hirschsprung's can develop enterocolitis, which can be life-threatening. Unfortunately, the treatment is surgical. And here is a barium enema. Now, a barium enema is not diagnostic. It can't tell you it's Hirschsprung's. It can make you think that, but the diagnostic thing is no ganglion cells. What is fascinating is in the early years when they started to first do surgery for these kind of diseases, they actually thought that the dilated bowel was the abnormal and the contracted was the normal. And they used to remove the dilated. Didn't work out so well. All right, and then there are these disorders that are what we call not quite Hirschsprung's disease. Hypoganglionosis. You do a biopsy, and there are ganglion cells, but not a whole lot of ganglion cells. And then there's something called intestinal neuronal dysplasia, and you look, and the nerve cells don't look quite normal, but they're there. So these are some diagnoses, and these are, again, in the fuzzy gray zone that they cause you to have stooling issues, but they're not quite Hirschsprung's disease, not classic Hirschsprung's. Pancreas. All right, so cystic fibrosis, pancreatic insufficiency. The pancreas is crucial, obviously, for digestion and nutrition. CF is going to be covered in the pulmonary section. Shwachman-Diamond is the number 2 cause of pancreatic insufficiency after CF. It's an autosomal recessive disorder. Basically, you see skeletal abnormalities, neutropenia, and pancreatic insufficiency. That triad pretty much makes you think Shwachman-Diamond. Johansson Blizzard, basically, is pancreatic insufficiency, nostril hypoplasia, or agenesis. These kids aren't going to sneak by in a lineup. They have cardiac hair, deafness, hypothyroidism, GU defects, and developmental delay. The other one that you need to know about is Pearson's pancreatic and bone marrow syndrome. Basically, they have pancreatic insufficiency with a macrocytic anemia, neutropenia, and thrombocytopenia. So all three major cell lines are affected in Pearson's. Basically, it's Pearson's bone marrow failure, and they have pancreatic insufficiency with that. That is, when you see all three cell lines affected and pancreatic insufficiency, it's Pearson's. All right. I think it's a response. So we have a child that develops pancreatitis after a traumatic blow to the abdomen. You should restart their feedings when the amylase is normal, when the patient is clinically improving, when the lipase is normal, or when the patient is pain-free. All right. So the right answer is when the patient's clinically improving. All right. So pancreatitis. Here are the etiologies of pancreatitis. Trauma, viruses, drugs, multi-system disease, ICU kids basically. Gallstones and anomalies. Gallstones are very rare in kids. The number one cause is trauma in children, and the number one trauma is bicycle handlebars. Literally, they stop too fast and then they get across the abdomen in their bicycle handlebars. How do you make the diagnosis of pancreatitis? In kids, it's clinical most of the time. The amylase can be normal. Lipase is usually elevated. The ultrasound will tell you if there's inflammation and fluid around the pancreas. CT, if you can't see it very well on the ultrasound. Sometimes you do an MRCP, a magnetic resonance cholangiopancreatogram, to visualize the ducts. Basically, the treatment, you do IV fluids, you do pain control, and you start feeding them again when they're clinically improving. In the old days, we'd wait till their amylase and lipase is normal. Well, you could be waiting a long time for that. You wait till they're completely pain-free. You can be waiting a long time for that. But when they start to be less pain, they're improving clinically, that's when you start to feed them again. Chronic pancreatitis. There are these hereditary pancreatitis syndromes. They're autosomal dominant, but incomplete penetrance once again. There's usually a family history. Mom, uncle, somebody in the family has a history of pancreatitis. 80% of these will show up before age 20. There's some unique defects in the CFTR that can lead to this. There's the SPHINK1, that's the most common. There's defects in trypsinogen that lead to hereditary pancreatitis. So if you see a child who has several episodes, you start looking for these hereditary forms of pancreatitis. After repeated bouts, the pancreas will scar down, they will develop pancreatic insufficiency, and a very, very brittle diabetes. All right, so now we're getting ready for the liver. All right, so we're back to the GI tract and nutrition. Again, the most important organ system in the body. As I pointed out, you guys remember, this is the first organ system to form, right? The tube gut, most important. The lungs bud off of it, right? The liver buds off of it. The pancreas buds off the foregut. You know, it's there before the heart. It's there before the brain. It's there before the reproductive organs. The GI tract is the core and center of our very being. The ancient Egyptians actually thought that the liver was the seat of the soul. So, let's go to the liver. So first off, let's talk about some congenital anomalies of the liver. So the liver, situs inversus and heterotaxia. Basically, the liver's in the center. These are extremely rare. They're associated with other anomalies, and what the funny thing is the liver usually does okay. The liver is pretty resistant, pretty good organ as far as that. It can be different places, but the liver functions are pretty good. Now, if you have a kid, though, and you see portal vein anomalies, then you've got to look for cardiac and urinary anomalies. That's the association. So any kind of portal vein anomaly, you look for cardiac and urinary anomalies. Congenital biliary anomalies. So I told you that what happens is there's a bud off the gut, and it interacts with the mesoderm and mesenchyme, and forms the liver. All right? But during that formation process, things can go wrong. And so the biliary tree can develop a choledochal cyst. Now, depending on where you look and the numbers you look at, it's 1 in 2 million to 1 in 13,000. And so if the duct doesn't work right, of course, what happens is you have stasis there, and you don't have good flow. You can end up with infections in this cyst, and then it will present with fevers and nausea and vomiting and pancreatitis because the pancreatic duct empties into there, and jaundice. And on ultrasound, you'll see the dilation of the biliary tree. Basically, the trouble with the choledochal cyst, because that it traps and has stasis of all these substances from the liver, those substances can lead to metaplasia, which eventually leads to cancer. So this is a high cancer risk if you have a choledochal cyst. Basically, it needs to be removed. The surgeons need to take that out and get that out. Other anomalies, 1 in 10,000 individuals lacks a gallbladder. Now, if you're lacking a gallbladder, that's associated with other anomalies. It's not uncommon at all to have a hypoplastic gallbladder. And there are studies now that show that 5% of the population have a floating gallbladder. Their gallbladder is not tacked down very well. And there is a small chance that could torse. So that's one of those things to keep in the back of your head. If you see something a little unusual, that's always a possibility. Congenital hepatic fibrosis. This is an association with autosomal recessive polycystic kidney disease. And for years, we see these kids. Now, some of them would show up in the renal clinic and they'd have polycystic kidney disease. And then some of them would show up in liver clinic with some liver findings, and then they would later seem to merge. And it basically, the diagnosis seemed to be whoever showed up first. And it's a developmental ductal plate abnormality, and in the liver it leads to fibrosis. So the fibrosis leads to difficulties with blood flow, which ends up causing portal hypertension. Now, the hepatocytes themselves, the liver cells, are normal. So these kids aren't jaundiced. They don't show up with elevated liver functions. What happens is somewhere between 5 and 13 years of age, they can show up with a life-threatening variceal bleed because they have portal hypertension because of the fibrosis and the blockage to flow in the liver. Kind of scary. Here's this kid who the parents have no clue, a lot of times, has any kind of chronic disease, and then they will show up with a life-threatening variceal bleed. Again, the liver functions are normal or mildly elevated. If it's severe, and you have severe portal hypertension, you need to think about a liver transplant because they are at risk for having continued variceal bleeding. These are always kind of interesting cases because I remember a 13-year-old who showed up with variceal bleeding. Turned out he had severe portal hypertension, and he went from being what the parents thought was a normal kid, and a few months later having a liver transplant. Kind of a big shift in thinking. Caroli's disease, again, another ductal plate disease. It's an autosomal recessive, and you have dilation of the intrahepatic bile ducts. Of course, they present with cholangitis as well. The bile doesn't flow well in these bile ducts, and they end up with stasis. If any kind of bacteria gets in there, they end up with an infection. You have to treat them with antibiotics. If you see this intrahepatic dilation with a congenital hepatic fibrosis, it's known as Caroli's syndrome. Dr. Caroli was a busy man. Alagille syndrome. Again, another French doctor named this one. This is an autosomal dominant disorder. It's a mutation in the JAG1 homeobox gene, which encodes for a ligand for the Notch1 receptor. It's called Notch1 because in Drosophila fruit flies it causes a notch in their wing. But basically this is what guides development and the development of some of the fibrous tissue. It's 1 in 100,000 births, so fairly common disorder. And these kids have this very characteristic triangular face. They have a very pointed chin, prominent forehead. And what in the liver you see is this very low number of bile ducts. They have paucity of bile ducts. And the kids present with neonatal cholestasis. Now, the good news is it gets better with age. But you don't want to do a Kasai procedure, which I'll talk about when we talk about biliary atresia on these kids, because these kids have intrahepatic bile duct paucity. It will get better. They do not have biliary atresia. Now, this is associated with some cardiac defects, the most common being peripheral pulmonic stenosis, but occasionally you can see something as severe as tetralogy of Fallot. Other things on this, again, this is fibrous tissue development. You'll see butterfly vertebrae. You'll have an abnormal radius and ulna, and they'll have something called posterior embryonal toxin in the eye, which you need your ophthalmologist friends to help look for if you think the kid could have arteriohepatic dysplasia. All right, so here we go. General peds, good. Here's a good general peds question. A jaundiced high school student is found to be positive for anti-hepatitis A IgM. Who do you have to give immunoglobulin prophylaxis to? High school classmates, his coworkers, his bus driver, or his household members? Who needs prophylaxis? All right, good. The household members. All right, so hepatitis A is an RNA virus. It is fecal oral transmission. All right? So, someone who gets it, in theory, as long as they practice really good hygiene, are not highly contagious, in theory. Hygiene, teenage boys, never mind. Incubation is 15 to 50 days. Again, the diagnosis is by the IgM for hepatitis A. There are no chronic forms of this. It does not become chronic. But 1% will be fulminant, and they can have very significant liver failure with that. So that's a fairly substantial number. IgG prophylaxis works. Who needs it? Well, household contacts, daycare, because they're taking care of kids who they're changing diapers and things, and so the fecal oral thing. Daycare, again, they're incontinent sometimes in daycares, nursing homes, same kind of thing. Not hospital, school, workplace, or day-to-day contact. Again, the vaccine is now recommended for hepatitis A, that we vaccinate kids for this. 1% fulminant, and when you have fulminant liver failure, it's very significant. So we are now trying to prevent this disorder. Hooray. Hepatitis B. Now, Hep B is unique because it's actually partially double-stranded DNA. So it's the only one of these that is actually a DNA virus. It comes from serum or blood products. The incubation can be 1 to 6 months, so very prolonged. What happens is you present with this prodrome, and you'll have these constitutional symptoms. You have fever, arthritis, urticaria, angioedema. And what's so funny is that sounds like a flu bug. A lot of people think they have the flu or something. They don't realize they've gotten hepatitis B. And so then all those symptoms go away, and then they develop jaundice. And whoops, lo and behold, you check and they got hepatitis B. Now, we can prevent them from developing hepatitis B if you treat them early with immunoglobulin. The trouble is, when the immunoglobulin would be effective is when they aren't aware they even have the infection. That's kind of the problem with the immunoglobulin. It works, but you have to know you were exposed in the first place. So there is an association. Hepatitis B, of course, sets up a chronic hepatitis. But there's an association. The younger you are, the more likely it is to become chronic. Infants, the chronicity risk is 90%. If you're 1 to 5 years of age, it's 25 to 50%. You flip a coin. And if you're over 5 years of age, it's 5%. Less than 1% of these are fulminant. But the trouble is 5 to 7% overall become a chronic carrier of hepatitis B. So this chronic hepatitis B has 3 presentations. One is asymptomatic. They have hepatitis B and they have absolutely no symptoms, at least as far as they can tell. Chronic persistent. There's a virus there. They're still making virus, but they have very little other symptoms. And then chronic hepatitis B. In adulthood, this progresses to cirrhosis, and there's a very, very strong association with hepatocellular cancers, unfortunately. Hepatitis C. This is an RNA virus, blood or serum again. It is the #1 cause of liver disease and liver transplantation in adults. All right? Now, many folks, of course, get it during childhood. 70 to 80% of folks who are exposed will become chronic carriers of hepatitis. 70 to 80%. So this is a virus, if you get hepatitis C, a lot of folks, it becomes a chronic issue. 25% of folks who have hepatitis C will develop end-stage cirrhosis after 20 to 25 years. So if you develop cirrhosis, you're also at risk for hepatoma. And so again, this is a bad one. The good news is now there is an approved therapy that is available. And I always mispronounce it. I'm going to try it. Lenacapavir and sovosibavir. I usually call it by the company name. This is approved down to age 12 years if they have genotype 1 for hepatitis C. And the cure rates are in the 90% range. So this is a good thing. This, again, up there, bullet point number 2 is that it's the number 1 cause of liver transplant. We now have therapy for genotype 1. This gives you hope and gives me hope that we're going to be able to treat hepatitis C, cure hepatitis C. If we get enough people that are cured, maybe we can get rid of it, and we're not going to have to worry about our kids with the chronic hepatitis C and treating them and all that. If we can just get enough people treated, and it'll go away. Hepatitis D, again, this is an RNA virus, but what's interesting is it by and of itself can infect you. It requires coexistence with hepatitis B. It's no worse than active acute hepatitis B if you get it together. And it doesn't change your risk of developing chronic hepatitis B. However, if you get a super infection with D after you have B, it tends to be extremely severe. If you're immune to hepatitis B, then you must be immune to hepatitis D. Hepatitis E, fascinating virus. It's an RNA virus as well. Fecal oral spread. So it's a lot like hepatitis A. Kind of like the same idea. It is found primarily in the Far East, Africa, and Central America. So you see this in folks who have been traveling. We have a very mobile society now, and people are going all over the place all the time. We have people from all over the world living in our communities. Why hepatitis E is important is because it has a 20% fatality rate from fulminant hepatitis in the 3rd trimester of pregnancy. We're not sure what the mechanism is. Nobody knows why, but if you get hepatitis E when you're in your 3rd trimester of pregnancy, 1 in 5 will die from that. Hepatitis G, again, still not a lot of information on this one. It's bloodborne. The transmission seems to be like C. The good news is it doesn't seem to form a chronic disease, however. Epstein-Barr virus, or infectious mononucleosis. Again, this is a DNA virus. It's spread by infected secretions, most commonly saliva. Of course, I'm old enough to remember when this was called the kissing disease. Okay? And you'd get it, and they would wonder who you got it from, and there were all sorts of jokes. And anyway, it usually affects the liver. If you have Epstein-Barr, it can result in hepatosplenomegaly. You see in a large liver in a kid who's acutely ill, you have to think about mono. Mild to moderate enzyme elevations and jaundice. It can be fairly significant with Epstein-Barr virus. You check them. If they have an elevated IgM antibody titer, then you know they probably have Epstein-Barr virus. It's usually mild and short. However, it can be severe and longer duration. It can take several months to resolve. Several months. So, if you have a child with infectious mononucleosis and they have elevated liver functions, don't panic if they're not down after a couple weeks. This can be one of those things that takes a long time for it to cool off. Of course, folks who are immunocompromised, they're at risk for lymphoproliferative disease with this, and they get all sorts of badness. CMV, usually very mild. We don't necessarily see jaundice, but they will have other liver functions if they get CMV, if you check them and they have it. However, CMV tends to be very severe in neonates, and they have a severe liver disease with it, and if their liver is very bad and you do a biopsy, you will see these very typical inclusions in the hepatocytes. Our babies do not like CMV. Other viruses, and this is very important. Any virus tends to result in a slight increase in liver enzyme levels. All right? Crucial to understand this. So rotavirus will cause a mild bump in liver functions. All right? There's case reports of influenza causing significant elevations in liver functions. Now, I know that we now have a vaccine for chickenpox, right? Chickenpox, varicella can cause a pretty good hepatitis, a varicella hepatitis. And so in the old days, before the vaccine, about 1 or 2 times a year, I would get a phone call, and I'd have a doc, and he would say, hey, Mark, I got this kid with chickenpox, and I did some labs, and I know what's coming. And this kid's liver functions are elevated in the hundreds. I'm like, it's varicella. It's okay. Varicella will do that. So any virus, all right? So it's important to understand that. So if you have a child who has a viral illness, and it's clearly a viral illness, mild elevation of liver functions are okay. If it makes you feel better when they recover, you can recheck them. There are case reports of parvo B19 leading to fulminant liver failure. Again, a few case reports. So again, if you have a child and they can't find the etiology, it's one of the ones we look for. Gilbert's syndrome. Again, many of these liver disorders were named by French physicians and discovered in the French population. So it's not Gilbert's. The correct pronunciation, I'm told, is Gilbert's. This is an interesting one because it is 2 to 10% of the population have this disorder. It is a defect in the promoter of the bilirubin UDP glucuronidase transferase. All right? The gene itself, the conjugation gene, is normal. The enzyme it produces is normal, but the promoter isn't. So the problem is you don't make as much. And so if you check them incidentally, they'll have a mild elevation of their indirect bilirubin. Of course, when they get ill or they fast, they may get jaundiced. This is a benign condition. The enzyme works, it'll conjugate it eventually, it'll clear it out. There's usually a family history. Oh yeah, we've got this uncle, and every time he gets sick, he turns yellow. Oh yeah, mom does that, or dad does that. This is a benign condition. There's no treatment needed. You just need to be aware of it. There is a gene test for this, but because it is a benign condition, I will tell you the insurance companies will not pay to do the gene testing. So you have to have the clinical history and suspicion that this is Gilbert's, and then be aware of this disorder and that that's what it is. Now, on the other hand, we have Crigler-Najjar, and this is a defect in the gene itself. Now, type 1 Crigler-Najjar is a severe complete absence of UDP glucuronidase transferase. Again, you do DNA testing for this one, but basically, if this gene is not there, you don't conjugate bilirubin. Well, then you end up with toxic levels of bilirubin. So you either have a lifetime of phototherapy or a liver transplant to fix this. You need hepatocytes that contain the enzyme. The phototherapy works great when they're infants and they can't get the eye protection off. When they get to be the toddler age range is when they start having issues, and a lot of times that's when we end up referring them for a liver transplant because we can't sustain the phototherapy on an ongoing basis. Crigler-Najjar type 2 is it's a defect in the gene, but it has partial activity. The bilirubin is usually less than 10. It doesn't require any specific therapy. These folks will do okay. They don't get into trouble with Crigler-Najjar type 2. Dubin-Johnson syndrome. Now, this is a defect in C-mode MRP2 gene, and this is the transporter for the conjugated bilirubin. Once it has been detoxified and made by conjugation, this is what puts it into the bile. Well, if there's a defect in this promoter, the bile actually gets, the bilirubin gets stuck in the hepatocytes. And so they have this very mild conjugated hyperbilirubinemia. Now, since it's conjugated, it's not a toxic, so it doesn't damage the liver cells, but it gives you abnormal conjugated bilirubin levels. In a child with no evidence of other liver disease and you have conjugated hyperbilirubinemia, they have Dubin-Johnson syndrome. Rye syndrome. Now, this is something when I was young and skinny and had brown hair, that was one of the scariest things around. We had these kids and they'd had some viral illness and they were given aspirin to bring their fevers down. And then when they would present with this acute liver failure, and they had this hyperammonemic encephalopathy that was out of proportion to everything else, and their clotting was way off, and basically, again, it was aspirin use of the viral infection. And now this is believed somehow in the presence of a viral illness to be some sort of a mitochondrial difficulty. Since we don't use aspirin in kids anymore, that whole Rye syndrome has gone away. However, there are a lot of metabolic disorders that mimic this and present this way. A lot of people worry about the subsalicylate, like in the bismuth subsalicylate, like we use the Pepto-Bismol, those kind of things, like some people are going back to use for H. pylori therapy. In theory, it's a salicylate, and it could be a risk factor. It hasn't been described, but in theory, it could be. Alpha-1 antitrypsin deficiency. So, our body makes all sorts of digestive enzymes. Good thing. I like digestion. I like to eat, so I like digestion. However, sometimes there's a problem if you don't control these. 1 in 2,000 births, you have kids who don't make an antitrypsin. We make digestive enzymes. We have to have an antitrypsin to control them, to regulate them. So some of these kids who have this alpha-1 antitrypsin, about 10 to 15% of the kids who have alpha-1 antitrypsin deficiency will show up jaundice at birth. And half of them will have elevated liver functions. So you measure, actually what you do is you actually measure the alpha-1 antitrypsin levels and you phenotype it. And this is an electrophoresis. And so the phenotypes, M is normal, S is mild, and the Z is of very low levels. Well, the Z folks are the ones that develop liver disease in the long run. Of course, we are a milieu of a lot of different enzymes. We have different enzymes that we inherit and different genetics, and half of your genetics are from mom and half from dad, and so there are other enzymes that are involved in other antitrypsins. So not everybody who has alpha-1 antitrypsin deficiency develops severe liver disease or the lung disease, and some people do. Some people progress to liver failure. And again, it's probably the other genes that you inherit in the subset of antitrypsins. But we do see kids who develop chronic liver disease who have alpha-1 antitrypsin deficiency. Of course, you also need to tell these folks to stay away from cigarette smoke because they tend to develop emphysema as young adults if they're exposed to things that lead to lung breakdown, which is the other thing that you see with alpha-1 antitrypsin deficiency. Wilson's disease, 1 in 500,000 to 1 in 100,000. And this is a disease of copper accumulation. We control copper by excretion. We get rid of it if we don't need it. The trouble is, if there's a problem with Wilson's disease, the excretion doesn't happen. And so you accumulate copper over time in your liver cells where we store it. So the gene is on chromosome 13, and over time you accumulate it, and then usually somewhere in your adolescent years, you develop enough of a toxicity from the accumulated copper that you end up with symptoms. One of the main organs affected is the liver. It also affects the kidney, the brain, and the eyes. In the eyes, you see the Kaiser-Flasher rings. It can have acute or chronic liver diseases. Some folks have more neurologic symptoms. You can have an acute hemolysis. Psychiatric problems, behavioral change, Fanconi's, or an unexplained bone disease. Basically, ceruloplasmin is the way you screen this. Like family members of patients, the better test is a serum copper or a 24-hour urinary copper. The gold standard is to do a liver biopsy and measure the actual copper level in the liver biopsy. Of course, you have to have a certain minimum of liver tissue obtained. So it's a pretty good chunk of liver. The treatment for this is chelation. The classic one is penicillamine, which basically chelates the copper and remove it so it can be excreted in the urinary system. You also do a low copper diet and supplement with zinc, because zinc comes in through some of the same pathways, and zinc will block the copper uptake. Hemochromatosis. Hemochromatosis is excessive iron storage. There is a hereditary form of this. It's a mutation in the HFE gene Fortunately, that accumulation really doesn't reach toxic levels until you're an adult. So we don't see that in childhood. There is neonatal hemochromatosis, and it seems to be due to a severe liver injury prior to birth. And the mortality in neonatal hemochromatosis is over 100%, is over 90%, close to 100. They have cholestatic jaundice, and they have a severe coagulopathy and ascites at birth. They're born basically with liver failure and coagulopathy, and it is not fun. The other thing with excessive storage of iron is transfusion-induced hemosiderosis. These are kids with transfusion-requiring disorders. We see this some of our kids who have hematological oncology disorders, and they get a lot of transfusions, and then they end up with a lot of liver in their, a lot of iron in their liver, it's a tough problem because they need the transfusions. But then what do you do with the iron? You're always balancing: do they need it, or can we wait? Progressive familial intrahepatic cholestasis, or the PFICs. There are 3 of these. Again, I talked about transporters. These are the bile transport defects. So bile is an important digestive juice, and I'm going to talk about that in the nutrition section. But basically, it has to get transported from the hepatocytes into the canaliculi to get eventually into the biliary tree. So PFIC1 used to be known as Byler's disease, and it presents about 3 to 6 months of age. And these kids have a very high conjugated hyperbilirubinemia. What's interesting is also they have this severe, and I mean severe, unremitting pruritus. Fascinatingly, the GGT is normal, which is primarily made in ductal cells. And then this PFIC1 gene is on chromosome 18. PFIC2, the gene, is the SPGP gene, which is on chromosome 2. These folks don't tend to have pancreatitis or diarrhea, have very prominent liver disease, and again, a normal GGT. PFIC3, these kids also present with cholestasis. They tend to have an elevated GGT. They're not as jaundiced as PFIC1 and 2, but the pruritus is still severe. All 3 of these disorders have pruritus out of proportion to the liver disease that you see with other liver diseases. They have this drive you crazy level of itching that the patients have. So if you have a child who presents with cholestasis, there is now this gene chip available. And basically, it works really good for neonatal jaundice. It gets arteriohepatic dysplasia, alpha-antitrypsin deficiency, and PFICs 1, 2, and 3 on this one chip. And it will get over 50%. It'll find over 50% of the causes of neonatal jaundice. So that's pretty good. Pretty quick test as well. Hepatotoxicity. We got to talk a little bit. The liver is a detox center. That's where we conjugate. That's where we detox a lot of things that come through. Acetaminophen. This is dose dependent. All right? If you take too much Tylenol, you will saturate the clearance system. It will shunt to another pathway and make a toxic metabolite that is hard in the liver. Now, you can give this antidote of N-acetylcysteine, which helps get around that and prevent that. On the whole, this is dose dependent, as I said. Most kids with liver disease, the least toxic thing to use for them is acetaminophen. Because of the toxicity and the high level and the dose dependent toxicity, a lot of our residents think that kids with liver disease, we don't use Tylenol. Well, we would rather use Tylenol in kids who have liver disease than some of the ones that have platelet effects and bleeding effects. So this is an important thing to understand. Acetaminophen is actually good for kids with liver disease compared to other drugs, as long as you don't give them a toxic dose. You don't give somebody with liver, you don't say no acetaminophen for people with liver disease. You just don't give them a toxic level of it. All right? This is very important. This will help your gastroenterologists back home. Other things that cause drug toxicity in the liver: phenytoin, sulfasalazine, halothane, antibiotics, erythromycin, trimethoprim sulfamethoxazole. Our adolescent male athletes who are thinking that they can take androgens and it will get them pumped up and give them a scholarship to a Division I school. They like that. Oral contraceptives, of course, are associated with hepatic vein thrombosis, the Budd-Chiari syndrome, and it's also associated with liver tumors, some of which are benign, but you have to stop the oral contraceptives, and they will tend to involute. Autoimmune hepatitis. There are basically 3 types of autoimmune hepatitis. Type 1, 2, and 3. Type 1 is the classic form. It's the one we see most of the time in kids. And basically, it's an anti-smooth muscle antibody or an anti-nuclear antibody that's positive. Type 2 is a liver-kidney microsomal antibody. Tend to see that not as often. And then type 3 is primarily adults. And that's a soluble liver, anti-soluble liver antigen. These kids present with an elevated aminotransferases. They will have hypergammaglobulinemia because you're attacking your own liver. You make lots and lots of antibodies. And usually there's a family history of autoimmune diseases. Again, autoimmune diseases, you have one, it makes you a risk to the others. They're treated with immune suppression because it's, again, an autoimmune disease. Corticosteroids, azathioprine, cyclosporin, tacrolimus. Depends on what you're familiar with and comfortable using. Fatty liver. I told you I'm from Memphis, right? We are one of the top spots for childhood obesity. We love fried foods. Just going to tell you. And we love our barbecue. If you like sticky sweet pulled pork barbecue, you need to come to Memphis because you would be in heaven. That said, it is not exactly food that is low in caloric content. So, we see a number of children who have non-alcoholic fatty liver disease. Now, this is associated with obesity and insulin resistance. We're seeing kids also with actual type 2 diabetes. These kids present and they'll have an elevated serum ALT or fatty liver on radiographic studies. Most of them are asymptomatic. You find it when you're looking for something else. Some will have a little bit of abdominal pain. You see these kids, they have a mild elevation of the liver functions. Do we do a biopsy? How deep and how far do you go? It's a lot of controversy because of the fact that these kids are fairly asymptomatic. You usually do some screening tests, but a liver biopsy is a fairly high-risk procedure, especially if the kid is very overweight, has a high BMI. How far and how much do you go looking for it? Now, non-alcoholic fatty liver disease can progress to NASH. Non-alcoholic steatohepatitis. Have enough fat, you start to get inflammation, you get fibrosis as a result of that, and you can eventually develop cirrhosis. NASH in adults is now the number 2 cause of a need to be liver transplanted. Of course, we're worried. We're all about prevention in pediatrics. We're worried about all these kids that we have that are NAFL. Are they going to progress to NASH? And are they going to end up with this, needing a liver transplant because of their fatty liver disease? Of course, the only effective treatments, weight loss and exercise. Weight loss and exercise. And you can preach it, and you can teach it, and you can talk it, and you can walk it, but it's a tough sell job. There is a little literature on vitamin E, but it's not definitive, and it's not perfect, and the best therapy would be weight loss and exercise. Primary sclerosing cholangitis, PSC as we like to call it, is assumed to be an autoimmune process. We don't know for sure, but it is a chronic inflammation in the biliary tree that leads to fibrosis of your bile ducts. It is associated with inflammatory bowel disease, usually ulcerative colitis. You diagnose it, you do a cholangiogram, and you can do a ERCP, and you see this beaded appearance. They're beading on the biliary tree. Unfortunately, there's no direct therapy. You use choleuretic agents. You make sure they have the salt-soluble vitamins. If it gets severe enough, you end up doing liver transplant. Again, it's assumed autoimmune because it is associated so strongly with the inflammatory bowel diseases. Neonatal hepatitis. Nobody knows what causes this. Again, it's idiopathic. It's the neonate who has elevated liver functions. You don't know why. If you do a biopsy, you'll see these multinucleated giant cells, which is very pathognomonic for neonatal hepatitis. You have high enzyme levels. The GGT is usually normal because it's in the liver itself, not in the ducts, and the elevated bilirubin, and it can appear up to 3 months. Most of them, if you treat them, you support them, and it will resolve spontaneously by 8 months of age. Lots of theories what neonatal hepatitis is caused from. Nobody knows for sure. Agonist syndrome. This is one of those rare esoteric disorders that board question writers like. This is looking for the person who remembers esoteric facts. Yeah, we all know people who are good at Trivial Pursuit. This is an autosomal recessive disease that presents in Norwegian newborns or people who are, of Norwegian extraction. They have severe cholestasis and they have lower extremity lymphedema. All right, and that is the association with Agonist syndrome. All right, audience response. Been a minute. Let's do one of these. We have a 1-month-old. Presents because he has become yellow. The parents also relate that the stools have become very light, but his urine has become very dark. The lab studies show the bilirubin, transaminases, and GGT are all elevated. So the definitive study we need to do to make this diagnosis is a cholangiogram, an ultrasound, a radionuclide scan, or an alpha-fetoprotein level. Yeah. All right. The definitive test, it said definitive study. The one that makes the diagnosis is a cholangiogram. So this is a vignette suggesting this patient has biliary atresia. In pediatrics, this is the number one indication for liver transplant. These kids are not born jaundiced, so they aren't presenting in the newborn nursery. So they go home, parents start feeding them, and then about a month of life, they start to develop a little jaundice. Their stools start to get clay-colored, and they start having dark urine. If you check liver functions, they're going to be elevated, and the GGT is going to be elevated. An ultrasound, you don't see a gallbladder. And if you do the radionuclide scan with the high substance, there won't be secretion. It won't get out of the liver. It'll be stuck in the liver. The definitive test, though, is to show sclerosis of the biliary tree, and that's an intraoperative cholangiogram. Basically, if you suspect it, you do these other tests to make sure that it isn't. If you see excretion, for instance, on the radionuclide scan, well, then the duct is intact, and it's not biliary atresia. You're basically trying to, if you see a good gallbladder, it makes it less likely that it's biliary atresia. You do the other studies to rule out, make sure you are ruling out biliary atresia. The sooner, of course, you're identified, if you have biliary atresia, the increased chances of a successful surgery. The surgery is called a Kasai procedure. What they do is, since the biliary tree is sclerotic, they take a loop of bowel and bring it up. They ream out the liver hilum and use that loop of bowel to create a new drainage conduit. And it's a Roux and Y, because it looks like a Y procedure. It allows the liver to drain. Basically, it delays the need for liver transplant. Some kids altogether, it does seem like even though you've done this Kasai procedure and there's drainage, even if it's got great drainage, there seems to be some sort of progressive sclerosis that continues in the liver over time, and years and years and years down the road, a lot of them will still come to a need for transplantation, to be honest. Of course, there's no sphincter of Oddi, and so there's risk for ascending cholangitis that we see with these kids who have a Roux and Y limb. And basically, you have to be aware of that. These kids will present with episodes of ascending cholangitis, and every episode hastens the liver disease and the progression of it. There are a very small number of kids who are born with biliary atresia, and those are associated with other syndromes and other anomalies. So if you see a kid that presents early, it's kind of an unusual finding, then you got to look about other anomalies, and there are some out there associated with biliary atresia. Gallstones. Usually the kids who have gallstone disease, there is a disease that puts them at risk. For instance, sickle cell disease kids have increased incidence of gallstones. They have hemolytic disease. Long-term parental nutrition tend to develop gallstones. Short bowel syndrome kids, because they're on long-term TPN. Pregnant adolescents tend to develop gallstones. We are doing more and more ultrasounds in kids with time. And the studies are finding now that we see a lot of kids who have incidental gallstones. Normal liver functions, no evidence of any kind of liver disease. Of course, you're doing an ultrasound for some reason, belly pain or something. But it appears that a lot of these kids have incidental stones. The more you look, the more you find them. If you don't have any evidence of liver disease, it's probably incidental. Although it drives the parents crazy to know that there's a gallstone in there. It can be small. And there can be no evidence of cholestasis, no evidence of any liver disease at all, but it drives them crazy knowing that it's there. But the recommendation is if they have no evidence of gallstone disease, just to follow it. Here is a gallstone, however. There in the center, you can kind of see the duct. It's dilated, and you can see a stone in it. Cholecystitis. All right. Again, rare in kids. Rare in kids. Very, very unusual. You see increased white count, right upper quadrant pain, mild increases in their liver functions and bilirubin. You get a hint with liver ultrasound. That's probably the best way to look at this. You look at it, and you'll have the hints that there's some sort of cholestasis. In kids, we see it without stones, but it's usually after some sort of a severe illness. These are kids who've been in an ICU. We see cholecystitis in kids who've been transplanted. They've been burned. They've been in severe traumas. They've been in the ICU. These are the kids that we see developing cholecystitis. Gallbladder eye drops. All right, guys. So there are several things here in this list that are associated. If they give you a vignette and the kid has gallbladder eye drops, it's probably one of these disorders. Kawasaki's, let the good times roll. You guys are too old for that reference, aren't you? Streptococcal pharyngitis, prolonged fasting, which we never see in Memphis. Parental nutrition, and Henoch-Schönlein purpura. And the eye drops will resolve when the process that caused the eye drops resolves. Liver tumors, these are rare. Rare. Liver tumors are rare in kids. Usually in the right lobe, they're usually benign. We see a lot of hemangiomas in the liver. But again, in a way, that's not even a liver tumor. It's a blood vessel abnormality. It just happens to be in the liver. Adenomas, hamartomas, focal nodular hyperplasia. The most common malignancy is hepatoblastoma. That's in infants. They have an extremely elevated alpha-fetoprotein. If you can, you resect it. Some kids need an emergency transplant if you can't remove it totally, if it's just so involved in so much of the liver. This is a picture of a liver teratoma. Again, one of the rare tumors that you can see. When you look at that right lobe there, you can kind of see there's different textures, there's some fluid parts, there's different kind of tissues in there, and so that's a liver teratoma. Again, a benign tumor. High yield pearls on the GI tract. Number one, pearl is the most common cause of abdominal pain and constipation in children is functional. Bloody stools. I broke this down for you because some people came up in the break and asked me questions. All right, so bloody stools. Age is the big divider here. Early infancy, you think formula allergy. Late infancy, you think intussusception. Before 2 years of age, you think Meckel's. Preschools, when you see the polyps. Polyps have to grow. They have to develop. You may have it developing when you're young, but it doesn't cause bleeding until you're a little older, got big enough to cause you symptoms. In a school-age child, you have bloody stools, you think dysentery, some sort of infectious etiology. And then in an adolescent, that's when you start to think about inflammatory bowel disease. Very rare before puberty. Other pearl, almost any virus, you name it, I'll claim it, will give you an elevation in your liver functions. Some more than others, but almost all of them will. And remember, the tube gut forms first. The other systems bud off or separate off. Fistulas and atresias are interrupted processes. All right? That helps to understand a whole lot of these atresias, fistulas, and all that. All right. Thank you.